Up next, we bring you a House Energy and Commerce Subcommittee hearing focusing on smoking and health.
It's a very great pleasure for us to welcome back to the subcommittee Dr. C. Everett Koop, the U.S. Surgeon General. He has been a superb head of our government's health effort over the years and has given us repeatedly very productive and very helpful testimony. Mr. Koop, Dr. Koop is accompanied by Jack Henningfield, who is Chief of the Dependence and Abuse Potential Assessment Laboratory of the National Institute on Drug Abuse's Addiction Research Center. We are also pleased to welcome back Dr. Frank Young, Commissioner of the Food and Drug Administration, who also is an old friend of this subcommittee's. Now, Dr. Young, I understand that your schedule is tight and that it will be necessary for you to leave about 10 o'clock, no later than 10, and we very much appreciate your willingness to spend even this limited time with us. So I presume this panel will be over about 10 or a few minutes after. All of us up here have agreed that we will defer our opening statements so that we will have time both to hear your testimony and to use that time most productively in questions and answers. And I very much appreciate my colleagues' consideration in joining me in deferring our opening statements. Your testimony, as it's prepared, will be printed in full in the record. So I suggest that each of you chat with us for perhaps 10 minutes informally, as if we were all in a living room together. And then after the three of you have testified, we'll use the remainder of the period for questions and answers. Okay? So, Dr. Koop, why don't you begin?
Thank you, Mr. Chairman. I would remind you that the time constraints apply to all of us, and we're grateful to the subcommittee's understanding that due to these prior commitments, we have to leave here at 10.
You all have to leave at 10. Then
yes,
let
sir.
me ask you to keep your opening statements to about 6 or 7 minutes.
All right.
That'll be 20 minutes of opening statements and another 25 minutes of Q&A. Okay?
Thank you. I will be talking primarily about the Surgeon General's report, which was released on May 16th, The Health Consequences of Smoking, Nicotine Addiction. This is the first such Surgeon General's report that focuses exclusively on smoking behavior, and it examines the question of why people continue to smoke despite a desire to quit and despite the known health hazards of smoking. It represents a most comprehensive review of the evidence that the use of tobacco is addictive behavior. Let me summarize the scientific evidence that led to 3 overall conclusions in this report. First, cigarettes and other forms of tobacco are addicting. Second, nicotine is the drug in tobacco that causes addiction. And third, that the pharmacologic and behavioral processes that determine tobacco addiction are similar to those that determine addiction to drugs such as heroin and cocaine. The determination that cigarettes and other forms of tobacco are addicting is based on standard criteria used to define drugs as addicting, and all of these criteria are met by tobacco just as they are met by other addicting drugs such as heroin and cocaine. There are 3 primary criteria. One is that there is a highly controlled or compulsive use of the drug. This means that drug-seeking and drug-taking behavior is driven by strong, often irresistible urges and can persist despite a desire to quit or even repeated attempts to quit. Second, the drug, in this case, nicotine, has psychoactive or mood-altering effects in the brain. And third, the drug itself is capable of functioning as a reinforcing agent that directly strengthens behavior, leading to further drug ingestion. The report also considers additional criteria that characterize drug addiction. Nicotine, like other drugs commonly recognized as addicting, meets these criteria also. For instance, the patterns of drug use are consistent and repetitive. Drug use may persist despite adverse physical, psychological, or even social consequences. And after quitting episodes, the resumption of drug use or relapse often occurs. Urges or cravings to use the drug may be recurrent and persistent, especially during drug abstinence, and diminished responsiveness to the effects of the drug occurs over time, a phenomenon which is called tolerance. Withdrawal symptoms often occur after cessation of drug intake, And finally, the drug itself can provide effects that are considered pleasant and euphoric to the drug user. Like other addictions, tobacco use can be effectively treated, and a wide variety of behavioral interventions have been used for years. Now we have even a physiologic response to be used as treatment, and that is nicotine replacement therapy in the form of a nicotine chewing gum. And these treatments are not widely available to the smokers who need them, unfortunately. Most third-party insurance payers do not provide coverage for smoking cessation, but on the other hand, they do for alcoholism and illicit drug use. Many smokers are able to quit on their own, but similarly, many users of other addicting drugs are also able to quit on their own. These individuals have learned to deliver effective treatments to themselves, or perhaps their environmental circumstances have changed in such a way as to support cessation and abstinence. And I should like to emphasize that those who want to quit should not be discouraged by anything in this report that I presented. National surveys indicate that 75 to 85% of smokers would like to quit. More than 40 million Americans have done so despite the addiction. And for many smokers, a desire to quit, and if necessary, persistent and repeated attempts to quit, may be all that is necessary. There are public health implications to all of this, such as how should we address the problem of tobacco use now that we recognize it as an addiction. Children especially should be warned about tobacco addiction through school and community education programs. Many children and adolescents who experiment with tobacco believe that they will be able to quit in later years, unaware that initial use can lead to a lifelong addiction to nicotine. And we, you and I, in concert with citizens of this country, civic leaders, should establish appropriate public policies on how tobacco products are sold and distributed to our society. Most importantly, we must give tobacco and tobacco addiction the sincerity, attention that it deserves. We have waged enormous resources in a war on drugs, illicit drugs, but we should also give priority to the one addiction, tobacco, that is killing more than 300,000 Americans each year. That's a very brief summary of my remarks, Mr. Chairman. I'll be happy to respond to questions later.
Dr. Henningfield.
Mr. Chairman and members of the committee, I'm Dr. Henningfield. I'm grateful for the opportunity to participate in this hearing on nicotine addiction. Adam Ha, through the NIDA Intramural Grant Program and the Addiction Research Center, has supported studies directed towards the understanding, treatment, and prevention of tobacco use. This research has had practical public health benefits, such as more objective and accurate diagnostic criteria for nicotine dependence and withdrawal. The research has also led to the development of more effective nicotine dependence treatments, since approximately 80% of the more than 50 million Americans who smoke would like to quit. These steps could have considerable public health impact. In addition, the involvement of nicotine dependence in the development and course of other addictions has also been increasingly recognized as one of the many factors to consider in the current war on illicit drugs, especially at the prevention level with programs aimed at youth. The conclusion that nicotine is a drug that can result in a similar addictive process as that produced by drugs such as morphine is supported by many lines of evidence, including surveys of polydrug abusers and even the more recent neuroscience research, which is investigating the mechanisms by which nicotine activates functional brain nicotine receptors. Let me begin by describing some features of nicotine dependence. Nicotine dependence, like other drug addictions, is a progressive, chronic, and relapsing disorder that can be objectively diagnosed. Levels of use range from low levels of intake to those which are highly resistant to change by either the individual or by others. Let me tell you how addictive nicotine can be as viewed by the so-called hard drug users and by alcoholic populations. 3 surveys of cigarette smokers, some of whom were alcoholic and/or of whom abused illicit drugs, showed that by several measures tobacco was highly addictive. The results of these 3 studies in Canada, Great Britain, and the United States were consistent. They showed that when asked to rate how much they needed the drugs and how much they liked the drugs and how difficult it would be to quit, that they rated cigarettes and other forms of tobacco as addicting as heroin and alcohol, and that they needed heroin and alcohol as much as, or tobacco as much as heroin and alcohol. Of course, many behaviors can become regular, habitual, and hard to give up, and they may also involve the ingestion of a substance. What sets drug addictions apart from these other so-called addictive behaviors? Primarily, it is that administration of the substance results in the delivery of a drug that is known to be addictive. For example, the drug in opium-derived products is morphine, the drug in alcoholic beverages is ethyl alcohol, the drug in marijuana is tetrahydrocannabinol, and the drug in tobacco is nicotine. Without the drug factor, none of these substances, including tobacco, provides a satisfactory substitute for users. The characteristics of tobacco as a vehicle for nicotine delivery have been most eloquently described by Dr. William Dunn of the Philip Morris Research Center in 1972. Dr. Dunn wrote, "The cigarette should be conceived not as a product but as a package. The product is nicotine. The cigarette is but one of many package layers. There is the carton, which contains the pack, which contains the cigarette, which contains the smoke. The smoke is the final package. The smoker must strip off all these package layers to get to that to which he seeks. Think of the cigarette pack as the storage container for a day's supply of nicotine. Think of a puff of smoke as the vehicle of nicotine. Smoke is beyond question the most optimized vehicle of nicotine, and the cigarette the most optimized dispenser of smoke." Many studies, including those conducted by NIDA, have supported Dr. Dunn's observations. These have shown that both smoked and smokeless forms of tobacco are efficient vehicles for nicotine delivery. They all produce substantial levels of nicotine in the blood of users, and in fact the levels are often many times higher than would have been tolerated when the person first began to use tobacco. Such levels activate many physiological systems which can affect mood, behavior, and general physiologic functioning. Once you know that substance results in drug administration, the next question is, how does this drug compare to established addicting drugs? To find out, both animal and human studies are conducted. In the case of nicotine, both polydrug abusers as well as smokers who are not addicted to other drugs have been tested. Nicotine has been given by cigarette, by cigar, by a variety of routes, including intravenous injections. The results with both animals and humans show that nicotine is a potent and powerful psychoactive drug that affects the brain, thereby altering mood and behavior. In fact, the potency is more than 1,000 times more potent than alcohol and 5 to 10 times more potent than cocaine and morphine in producing like effects. In a technical sense, nicotine is also a euphoriant drug. It can produce pleasurable feeling states in humans. When compared to cocaine and heroin-like drugs on standard tests, some of the results that are critical are similar. These findings show that nicotine meets standard criteria as a euphoriant and has the potential to addict. That is, nicotine itself can produce much of the pleasure and satisfaction sought by the smoker. Addicting drugs also reward users by their chemical actions in the brain. That is how they drive or compel behavior. The standard test of the basic biologic power of a drug to drive behavior is to determine if animals will self-administer the drug. Several species of animals have been found to voluntarily take nicotine in such studies. But there is even more to nicotine addiction than what I've just described. Nicotine use, like heroin use, also leads to tolerance and physical dependence. Over time, daily nicotine intake increases until levels are reached which would have caused profound discomfort when the person first began using the tobacco product. These increases then become necessary just to sustain relatively normal mood, behavior, and physical functioning. Also, nicotine-induced physical dependence has also been extensively studied by NIDA researchers. The studies show that within the first day of abstinence, symptoms such as discomfort, craving to take an additional dose, inability to concentrate, disrupted cognitive performance, and mood changes occur. In addition, physiologic signs such as changes in heart rate, hormonal output, and electrical brain function occur. These effects are more severe in individuals who have been using higher levels of nicotine, and they are reversed by readministration of nicotine. Withdrawal symptoms can also lead to relapse if they are not treated. In summary and conclusion, the laboratory and clinical data confirm that nicotine is a highly addictive drug. The strength of the resulting addiction varies among individuals, but as a drug, nicotine is characterized by the features that result in addictions as strong as those seen for opiates, stimulants, and sedatives. Therefore, we conclude that nicotine is the prototypic or dependence-producing drug, and more specifically that the biological properties of nicotine can induce a compulsive use of tobacco. This role is equivalent to the role of cocaine and coca leaf use, to ethanol and alcoholic beverage consumption, and to morphine and opium poppy use. Thank you, Mr. Chairman, and I would be happy to supply any papers to support any of these points.
Thank you very much, Dr. Henningfield.
Mr. Chairman?
Yes.
Mr.
Bruce?
I'm sitting here concerned. The panel is, it's now 9:27. As I understand from Dr. Koop that he plans to leave here at 10 o'clock. I certainly respect his right to testify and leave, but it does put us, who are members of the committee, in the position of being mere listeners to written testimony. I wonder if their schedules are at least at all flexible, so that we don't get into the situation where the three gentlemen here testify and leave, because it leaves very little congressional role in the way of asking questions or getting responses. Had I known that they were going to testify and leave, it would have been easier to exchange written interrogatories and
Gentleman makes a good point. We have Dr. Young will testify for 5 minutes under the rules, and then each member will have an opportunity for a round of 5 minutes. That will put us pretty close to the 10 o'clock, and I assume our witnesses, if need be, will stay a few minutes over. Dr.
It seems particularly unfortunate that the witnesses are simply reading their testimony, which presumably we've already had.
The witnesses have 5 minutes to present their oral testimony however they see fit. Dr. Young?
Mr. Chairman, in respect to that, I will not read the written testimony as usual, as I usually do not, and will submit it for the record and only make a few points for your consideration. And I apologize, my deadline is 10 o'clock, and it is unavoidable. Most tobacco products are regulated by the Bureau of Alcohol, Tobacco, and Firearms. Tobacco products have not customarily, as marketed, been considered within the FDA jurisdiction, and my testimony outlines that in detail. It has, under the way in which the manufacturer presents it, been at times considered in the extract of nicotine as a drug, in the exception in the case of a drug called Nicorettes. In other instances, tobacco products may also be considered foods. The technology, as it's developing, continues to be innovative and thus makes increased problems for the Food and Drug Administration, and thus we examine these on a case-by-case basis. We currently are reviewing petitions, 2 of them on the R.J. Reynolds Tobacco Company proposed cigarette product that involves heating without burning of tobacco, and we have an additional petition that is before us on low-tar cigarettes. We will examine these carefully on a case-by-case basis, recognizing the past law, and I would call your attention to the fact that the Food and Drug Administration looks at all of the facts that were raised by Dr. Koop and others and focuses on what the drug means under the law, and I quote, "The term drug means A, articles recognized in the official U.S. Pharmacopoeia, official homeopathic pharmacopoeia of the United States, or official national formulary, or any other supplement to them. B, articles intended for use in the diagnosis, cure, mitigation, treatment, or prevention of disease in man or other animals. And C, articles, other than food, intended to affect the structure or any function of the body of man or other animals. And D, articles intended for the use as a component of any article specified in clauses A, B, C, but does not include devices or their components, parts, or accessories." So that as we are looking at this problem as raised, despite our concern and compassion for the issue of smoking, we are looking at, in our understanding, a law and trying to work through the statute as has been passed many years ago and interpreted through a number of court cases. Mr. Chairman, this ends my informal remarks.
Thank you very much, Dr. Young. Mr. Scheuer, I'm going to let you. Mr. Scheuer, I'm going to let you lead off on questions.
Dr. Young, I'm puzzled at our failure to our failure as a society to treat tobacco as a narcotic drug affecting the central nervous system. All of the testimony that we have heard this morning and that we're going to hear this morning indicates that the pharmacological impact on the human psyche and the human body of nicotine is very similar, especially in its addictive characteristics, to cocaine and heroin. The American people don't know that. Congressman Waxman and I, and a couple of other members of the subcommittee, Congressman Waxman as chairman of the subcommittee, arranged for us during last week, when we all happened to converge on Atlanta, to visit the Center for Disease Control. And when we asked them what would be the most effective research that government could perform to improve our national health outcomes, would it be research on all of the systems, the operations, the procedures, the drugs, which work, which don't work? Would it be research on arthritis, on mental disability, on incontinence? They said none of the above. It would be research on how we impress on the American people that they should pay attention to the research we've already developed about the dangers of alcohol, tobacco, and drugs. How do we get them to build and change their behavior based on what we already know? We don't have to know anything more for major health impacts, for our major health outcomes to improve. Now, I ask you, we seem to be dancing around the subject of whether tobacco is or ain't a narcotic drug, an addictive drug affecting the central nervous system. The three of you have all testified that it is. Now, Mr. Henningfield says in the last sentence of his testimony that he respects the where the hell is Henningfield? He respects the food and is this not correct, Mr. Henningfield? I can't find it right now. That you respect the decision of the Food and Drug Administration in their present interpretation that it's not a narcotic drug under that act. If the act doesn't describe tobacco or nicotine as a drug or not a drug, as you say, Dr. Young, for goodness sake, why doesn't our society, through your agency, say this is an addictive drug affecting the central nervous system, very similar in its addictive characteristics to heroin and to cocaine, and we should treat it as a very serious matter that has important implications for morbidity to the American public. Now, I don't think there are many people among us in American society who would want to ban tobacco. We tried that with alcohol a half a century or more ago. It didn't work very well. But short of banning it, wouldn't your declaration that this is a dangerous, addictive drug similar to cocaine, similar to heroin, and that we should, especially young people, should think most seriously, they should stop, look, and listen, and think about the impacts to their health of starting in on this awful, dangerous habit? Aren't there other things that we could do short of banning this product that nobody thinks would work, that would do what the CD says is the first order of business for us as a society, namely to teach the American public what we already know and teach them to adjust their behavior to avoid these awful health threats to them and take charge of their own behavior? Isn't it incumbent upon your agency to say, yes, this is an addictive drug affecting the central nervous system. It has the same addictive characteristics as heroin and cocaine. We do not advocate its ban. That's for Congress and the American public to decide, but the American public ought to be perceiving this as a dangerous drug urgently affecting their health. And wouldn't this sort of set the discourse and help the CDC with its problem?
Mr. Scheuer, the Surgeon General's efforts, which I applaud, have been very vigorous in trying to bring this forward as a major concern, and the packages of cigarettes themselves contain the Surgeon General's warning, and the Surgeon General's report clearly focuses on nicotine as an addictive agent. He also has, and I can truly attest, led these discussions at the World Health Organization, in the World Health Assembly, and in other fora that we have been together. The issue that I'm focusing on is trying to understand the law and its clarifications on what the agency's responsibilities are. We do have 3 petitions before us. This is the first time that I personally have had an opportunity to review this. We will be looking back at the history of the Food and Drug Administration, which has been to not regulate tobacco products and cigarettes as a drug, let alone a narcotic drug, but instead as a substance, cigarettes as substances that are used for smoking pleasure. Our keys, as we have to look at this, come not only as the intent of the particular product, and that's a very key part of the law that I raised, but in the petitions that we have received, they focus on, for example, if I may refer to one of these, the petitioners contend that this new nicotine delivery system introduced by R.J. Reynolds Company falls within the statutory definition of a drug because this product is intended to affect the structure and function of the body of man, and because this product is intended for the use in the mitigation, treatment, and prevention of disease. Other individuals contend differently, that this is not used as a drug. So this case-by-case analysis is what we're up to now. I think the Surgeon General, though, has vigorously led this educational effort, and one which he, I'm sure, will not flag from. I know his commitment to this.
Thank you, Mr. Shores. Thank you, Mr. Chairman. Dr. Coop, I'd like to ask you to place the role of nicotine as a drug in a bit of perspective for us. In your views, if nicotine-contained products were to be first invented at the present time, would they be permitted to be marketed to the American public without being treated as regulated drugs?
I don't believe for a minute that they would be, sir.
Could you comment, Doctor, on the desirability of legislation that would place nicotine-bearing tobacco products under the drug jurisdiction of the Food and Drug Administration?
I think on the basis of what Dr. Young has just testified, the law doesn't seem to cover the problem we're all discussing, and therefore I think the law should be changed in order that that be done. Whether it should be done specifically for tobacco or be a broader concept, I don't know. Whether FDA should be the regulatory agency, I don't know either, but certainly something has to change.
Dr. Young, I would appreciate it if you take note of that comment. As you may be well aware, myself and the chairman have a bill to introduce, or it's already been introduced, to do just that, which I think is long, long overdue. So I would appreciate the FDA becoming more active in its participation, sponsorship of that legislation.
We appreciate the guidance that you are giving and the actions that you're taking, and we'll provide whatever appropriate technical assistance we can and should. As to the best of my knowledge, there's no position been taken on that bill at this time.
Dr. Coop, from your recent report on the addictive nature of nicotine and tobacco products, it would seem that a major part of the battle to reduce the health damage caused by smoking is change the behavior of young people who may be misled into taking up the smoking habit. Do you see a positive benefit from federal legislation to assure that cigarettes are not available to minors and are not sold in vending machines or distributed as free samples?
Inasmuch as the earlier a youngster starts smoking, the greater is his addiction and the more difficult it is to get off of the drug, anything we can do to keep young people from starting is a better action for government to take than to try to correct the addiction after it has occurred. 37 some states already have laws on the books that prohibit the sale of tobacco products to minors, but in general they are not enforced. And of course, with vending machines where there is no one around to monitor what happens, that means that there's no possible way that you can keep a minor from buying those products. And in my report on addiction released in May, I was very clear and strong on the fact that vending machines available to youngsters should be abolished, and that the laws should be enforced where they exist and enacted where they do not.
It is a divergence, and I'm sure you would agree, Doctor, that almost a contradiction, maybe it'd be a better word, in the current policies that make it somewhat difficult for minors to obtain alcoholic beverages, and yet an addictive drug such as nicotine is readily available to them, and anybody that's gone into a quick shop or stands by a vending machine sees that, sees what even laws we've got blatantly violated. Dr. Coop, I understand that under the federal law, cigarette manufacturers must submit to you a list of all of the additives that they use and put into their cigarettes, but these are required to be kept confidential. Do you see any gain in the health awareness to be realized from changing the law so that the public knows exactly what goes into those cigarettes that are being sold to them here in the United States? And specifically, do you see a public health benefit from requiring the disclosure of all cigarette additives on cigarette packages and then permitting the FDA to ban additives that present an increased health risk to smokers?
I think that day may come, sir, probably lies in the not-too-distant future. I've heard it said that because I have not taken a stand against additives, that means I don't think that they're important. That's a false assumption. Nothing could be further from the truth. We have received from the tobacco manufacturers a list of their additives, and that is work that's being carried out now in the Office of Smoking and Health and not in the Office of the Surgeon General. They are reviewing all of the toxicological literature to see if any of the additives pose a health risk to the consumer. And it's my understanding that that work will be completed before the end of the calendar year. And when those figures and observations are in, I think that is a time to act if necessary.
Doctor, just one last question, just to give us a frame of reference here for the magnitude of the health problem we're dealing with by smoking. How does the number of deaths we can expect each year from smoking compare to some of the other major causes of death in the United States?
Well, I think pertinent to what we're talking about, the chart on the wall in the red, white, and blue gives you the same statistics I presented at the press conference in reference to this subject, but you'll see that if you add up alcohol plus other drugs and opioids and cocaine, the deaths each year are 10,000. Tobacco, on the other hand, is 320,000.
Thank you. Thank you, Mr. Chairman.
Mr. Bruce?
Well, Mr. Chairman, I think I'd just like to ask leave of the committee to submit an opening statement in whole before I ask questions, if that's all right with the chairman.
Without objection, all members' opening statements will be put in the record in the appropriate place.
Let me just make a couple of comments from my opening statement, though. First of all, I do think that it is unfair to have a hearing in which we are severely restricted in our ability to ask questions. Secondly, that this hearing is untimely. To have FDA decision makers such as Dr. Young testifying before the committee today is improper, I believe. It exerts pressure on the FDA to rule in favor of a pending petition. Such action, I think, is a threat to the impartiality of the FDA, and that is why they were created by the Congress, to make impartial decisions. In the Pillsbury decision in 1966, when a similar occurrence happened, the court ruled in the Fifth Circuit that legislative involvement in the judicial function of the FDA was inappropriate. It denied the litigants the right to a fair trial, and it also rendered the appearance of impartiality almost null. In the present matter, the FDA has not reached a decision on the pending petition to regulate a new cigarette. Once they render that decision, then I think it is quite appropriate for the Congress to review that decision-making process, see whether or not it was properly arrived at, hold hearings of the type scheduled for today. But until that ruling is made, I strongly believe that we should leave matters to the sound discretion and expertise of the FDA. In any event, the hearing is going forward, and I will ask questions of Dr. Coop, if I might. Dr. Coop, you've, in your press release in May and then again today, you draw very little distinction between cigarettes and hard drug addiction. But don't hard drugs distort perception, alter personality, and lead to bizarre behaviors on the part of the users? And wouldn't you agree with Dr. Charles Schuster, who is head of the National Institute of Drug Abuse, that where we have to, and this is a quote, where we have to make a big difference between tobacco and other addictive drugs is that when one smokes tobacco, it does not alter your behavior or your ability to function so that you become dangerous or obnoxious or an embarrassment to society. And he said that shortly after your statement in May. Do you agree with that statement that we ought to make a distinction between hard drugs and addiction to tobacco?
I was not aware of that statement, sir. I do think that some of the behavior of tobacco smokers fit the things you mentioned about other hard drugs. And I think one of the things that many people confuse is the behavior of hard drug addicts.
Your microphone.
Dr. Cope,
sorry.
Your microphone's not on.
Thank you.
I think one of the things that many people confuse is the behavior of cocaine and heroin addicts when they are deprived of the drug. Now, that's the difference between a licit and an illicit drug. Tobacco is perfectly legal. You can get it whenever you want to satisfy the craving. People say there's no crime in the streets in reference to tobacco. That is true. But if tobacco suddenly were as unavailable and was as expensive as heroin and cocaine, I think that you would find that the behavior of some tobacco addicts would be very much like the behavior of some addicts of heroin and cocaine.
Dr.
So I think we're dealing with two different issues, and they should not be confused.
But cigarette smoking doesn't impair a smoker's performance or his mental functioning in the same way as a hard drug does it. It isn't a question of price between a pack of cigarettes and however you sell cocaine.
Sir, the report that I gave had nothing to do with which was more effective in the behavior of people. My report was on the addiction to these three substances, and I stand absolutely firm that the addictive properties, pharmacologically and physiologically, are the same for those three drugs: heroin, cocaine, and nicotine.
And you don't see that families are destroyed by drugs, that crime is increased by hard drug use, that cigarette smokers don't break into liquor stores late at night to get money to buy a pack of cigarettes. I mean, you
take
see no
tobacco
distinction
off the
between
streets, sir, and there will be people breaking into liquor stores to get drugs to buy tobacco.
I find that hard. Dr. Coop, you seem to be stuck on the word addiction.
I'm absolutely stuck on the word addiction, and I am here discussing the report that I presented to the Congress on addiction, sir.
Right. But didn't you also in 1982 use the word addiction when you were talking about the use, quoted you as saying that young people are addicted to video games? And is that the same sense? I mean, are you saying that if video games, that kids are going to be breaking into liquor stores to get money for quarters for video games in the same addictive sense of tobacco?
Well, as a matter of fact, kids do that, but I was not talking about addiction in the same physiological, pharmacological sense, and I think most reasonable people understand that semantically we do use the term addiction when we more properly should use the term compulsive behavior, which is what I was referring to in reference to the behavior of youngsters toward video games. But none of those semantic differences have anything to do with altering my position or that of my colleagues on the addictive properties of nicotine.
And so it's not compulsive behavior. It is to video games, but it is addictive as tobacco. Is that the distinction you make?
I don't think I understand your question, sir.
You were saying about you use the word addiction as to mean compulsive behavior.
When I'm talking about video games, that is what I meant, and I say that it is not a good choice of words, but that does not affect my statement about the addictive properties of nicotine.
Bruce.
Thank you, Mr. Chairman.
Mr. Bliley.
Thank you, Mr. Chairman. Dr. Coop, you have no treatment experience with helping hard drug addicts or smokers attempting to quit, do you?
Yes, as a matter of fact, I do, sir. I was a surgeon with a broader understanding of medicine than just the surgical specialty. I have worked with drug addicts over the years, and since I have been involved in the problems this country has with AIDS, I have been working with addicts not only in this country but also in Amsterdam and in London and in 2 cities in Scotland. I'm not a therapist, but I do have more than a passing knowledge of these people.
Doctor, you use this term addiction. I want to read to you a statement and ask for your comment on it. This is a statement that was made by Professor Albert Hirsch, author of the report on tobacco to the French Minister of Health last October, and a vocal critic of the tobacco industry. Do you know Professor Hirsch?
By name.
On Tuesday, May 17th of this year, in an interview with French radio, Dr. Hirsch said, Professor Hirsch said, quote, "Tobacco cannot be compared to drugs, especially hard drugs like heroin or other narcotics. It is always bad to fight an evil with misstatements or distortions of the truth. It is completely excessive. We know that dependence on a substance in tobacco, nicotine, for example, only accounts for the motivation in smoking for about 10% or at most 20% of all smokers. Therefore, talk of addiction would mean comparing tobacco to something which completely alters the personality of the subjects, turning them into antisocial individuals, which we know is not the case with the overwhelming majority of smokers. We should resist this kind of discrimination and witch hunt that can be observed in some of the excesses of the anti-tobacco campaign in the United States."
My comment to that, sir, is that Dr. Hirsch, for all of his credentials and fame, has confused 2 things: addiction, on which he is absolutely incorrect in that statement, and the effects of hard drugs on the personality of individuals. They are separate.
Does the American Psychiatric Association use the term addiction when referring to tobacco?
It lists it as a substance. Does it call it addiction? It does, I think.
Uses the term dependence producing. Uses the term dependence producing, which is used in technical and medical literature, but the National Institute on Drug Abuse, when it's important to communicate information, uses the term addiction, whether it's to describe nicotine or cocaine.
Dr. Young, you have made known your concerns over the resource requirements that would be imposed on FDA as a result of enactment of the medical device amendments which just passed the House. What would be the resource impact on FDA if legislation giving FDA jurisdiction over tobacco was passed?
We do not have the technical expertise at this time for the evaluation of the variety of additives that Dr. Koop mentioned, as well as the detailed scientific base to focus on the regulation of a product of this complexity. Thus, there would be substantial resource requirements. I would also comment, as Mr. Bruce did, that I'm trying to be as objective as I can, and I have carefully said that we are looking at the petitions, and thus all the options are open to the agency, and we are not prejudging the issue.
Thank you. Dr. Henningfield, I'm sorry. Dr. Koop, your report on addiction was the 1987 report of the Surgeon General, and yet it was not released until May 1988, only a few days before the jury in the Cipollone case retired to begin its deliberations. It was released at that time with great fanfare. Can you shed some light on the coincidence of the timing of the release of the report with the climax of the Cipollone trial?
Yes, all of the reports that we release on smoking and health are released with what you call fanfare, sir. There was absolutely no planning on our part to make those two dates coincide. The reason that our report was late was because the Office of Smoking Health was taken out of the Office of the Assistant Secretary for Health, was placed in the Centers for Disease Control without any moving geographically of that office. In addition, we brought on Dr. Ronald Davis to head that department. With all of those changes, it was not possible, when you consider the size of the effort to get this report out, to produce it at the usual date in November or December of 1987. Therefore, it came out in the spring of 1988. But the date for that was chosen far in advance of any knowledge that we had that there was to be such a thing as the Cipollone trial in New Jersey.
Thank you.
Time has expired. Chair recognizes himself for 5 minutes. Dr. Koop and Dr. Henningfield, the tobacco industry contends that your use of the term addiction to apply to nicotine trivializes and almost mocks the serious narcotic and other hard drug problems faced by society and undermines efforts to combat drug abuse. Dr. Koop, how do you respond to that?
I don't agree with that. I think that the huge report that we produced made very clear that two terms are interchangeable, dependence and addiction, as Dr. Henningfield has already mentioned, because the public understands addiction and the scientists use the word dependence. We use them in the report interchangeably. But we stand on the record that the pharmacological and physical aspects of addiction and withdrawal are exactly the same for hard drugs that you've mentioned as nicotine, and I don't think it trivializes the addictive problem in hard drugs, but what it does is to bring to the attention of the public that smokers who are addicted are not just people who don't have the willpower to kick a dirty habit. These are people who really are addicted in every true medical sense of the term, and when they understand that, they will seek help. And I think it also provides a better understanding on the part of the public as to why they continue to smoke when they themselves would like to quit.
Dr. Henningfield, the industry believes that there are no more similarities between nicotine and heroin than, say, nicotine and caffeine. They state there's no substantial scientific evidence that smoking creates a physical dependence to nicotine. The specificity of the effect is still, after many hundreds of studies, relatively unknown and variable. How do you respond?
The fact is, sir, that if we're being objective, we cannot avoid the comparison among those drugs. They all produce tolerance, physical dependence. They're psychoactive drugs. Nicotine also can intoxicate. The reason we don't see it is because users become so highly tolerant. In addition, the data regarding nicotine go back to the turn of the century. Much of what we know about the functioning of the nervous system goes back to nicotine studies. These results, in that sense, are not fundamentally new. We have reconfirmed findings that have been about for many decades.
Now we have all of us we all think of cigarettes when we think about nicotine. This has been the primary way that people have become addicted to a habit that has produced this dependency. There are alternative delivery systems for nicotine other than cigarettes. Dr. Koop, your report specifically addressed concerns over the safety of these alternative nicotine delivery systems. What products are we talking about when we think about alternative delivery systems?
Well, the products have been proposed from time to time, and Dr. Young is much more knowledgeable about these than I am. One that I have seen recently is that produced by R.J. Reynolds, which is a smokeless kind of cigarette, which produces a tremendous ignition temperature, contains nicotine as a drug in the cigarette-shaped dispenser, contains tobacco to give flavor, but does not produce a smoke that is taken into the lungs of the user. Instead, it produces a jolt of nicotine, which provides the addictive producing problem of cigarettes without some of the smoke that goes with it.
How about chewing gum with nicotine? Is that another alternative delivery system?
There is on the market, sir, a gum that contains nicotine, which was produced as a nicotine delivery system in order to wean patients who are addicted to smoking away from the nicotine in that delivery system. It is not meant to be used in any other way. It is a crutch for those people who have made the decision to quit and are trying to come off and are fighting the problems of addiction.
Now, that's been approved by the Food and Drug Administration as a
Yes, sir.
as a drug, and it meant they found safety and efficacy in using it as an alternative to wean away from cigarette smoking. If we end up with this so-called smokeless tobacco, that would be a delivery system for nicotine as well. Are you concerned that rather than that be a way to wean people off smoking, it will be an alternative that people will become addicted to and use as frequently as smoking?
I don't know what all of the intent was of the manufacturer. I don't believe that that is a good weaning device because it is attempting to simulate all of the other pleasurable things that go with the process of smoking a cylinder that you hold in your hands and put in your mouth. So I would not put that in the same category as a beneficial use of nicotine to treat addiction as I would the nicotine gum.
Thank you. Gentlemen, I have additional questions, and I'd like to submit those questions to you in writing and have you respond, and I think we ought to have the opportunity for other members to submit written questions for written response for the record as well. Each member's had an opportunity to question you for one round, and we'll perhaps be able to complete the record through these written interrogatories that will be in the record. I thank you very much for being with us. We'll look forward to working with you.
We will answer your questions, sir, and we appreciate your understanding about our other problems.
Thank you very much.
Our second panel of witnesses will present testimony on the potential health ramifications of nicotine in general and the proposed smokeless cigarette in particular. Bill Schultz is an attorney with Public Citizen Litigation Group. Scott Ballin is chairman of the Coalition on Smoking or Health. John Slade is a physician from New Brunswick, New Jersey. Greg Connolly is a representative of the American Public Health Association. I'd like to ask them to come forward. Do we have everybody here?
No, John Slade is coming up here.
We want to welcome you to our subcommittee hearing today. Your prepared statements will be made part of the record in full. We'd like to ask you to limit your oral presentation to us to no more than 5 minutes. Mr. Ballin, why don't you begin?
My name is Scott Ballin. I'm Vice President and Legislative Counsel for the American Heart Association. But today I appear before this subcommittee on behalf of the Coalition on Smoking or Health, which is comprised of the American Lung Association, the American Cancer Society, and the American Heart Association. There are 3 reasons why this hearing is important today. First is the conclusive finding that nicotine in tobacco is an addictive substance. Second, previously How's that? Okay. Second, previously undisclosed tobacco industry documents reveal that the tobacco industry has long been aware of the addictive nature of tobacco products. and that there was a need to develop products which the public would perceive as safer, and that the tobacco industry has marketed its products with the intention that their products be drug delivery systems. These documents were produced and released only after a federal court order in the Cipollone case. For example, in 1972, a research report by William L. Dunn, a high-level researcher for Philip Morris, it was stated that the cigarette should be conceived not as a product, but as a package, and the product is nicotine. The cigarette is but one of many packaged layers. Think of the cigarette pack as a storage container for a day's supply of nicotine. Think of the cigarette as a dispenser for a dose unit of nicotine. Think of a puff of smoke as the vehicle of nicotine. In another report released by Philip Morris, a confidential report, it's further stated that even though nicotine is believed essential to cigarette acceptability, a reduction in the level may be desirable for medical reasons. Philip Morris and the other tobacco companies have done everything they can to suppress the release of their own internal research memoranda and to publicly portray as frivolous the scientific evidence that tobacco use is a form of addiction, despite their knowledge to the contrary. The third reason why these hearings are extremely timely is that we have recently seen the announcement of the introduction of a variety of new alternate nicotine delivery systems designed to further abuse the traditional reluctance of the FDA to assert its jurisdiction over tobacco-related products. Last fall, the R.J. Reynolds Tobacco Company announced its intention of introducing a new product, which it labeled a smokeless cigarette. In fact, this product is nothing more than a cleverly designed alternate nicotine delivery system designed to try to circumvent the authority of FDA. You will hear this product described by other witnesses this morning, so I will not go into the details, but I want to emphasize that we view this product as clearly falling under the statutory definition of drugs under the Food, Drug, and Cosmetic Act. No matter how carefully and how cleverly RJR tailors its public statements about this product, there can be no question that the product is intended to be used as a nicotine delivery system, and it is intended to affect the functions and structure of the body, as well as being intended to be marketed to consumers who will believe that this product will help them avoid the risks of disease associated with smoking. Ed Horrigan, Chairman and Chief Executive Officer of R.J. Reynolds, publicly stated, and I quote, "Since the tobacco does not burn, a majority of the compounds produced by burning tobacco are eliminated or greatly reduced, including most compounds that are often associated with the smoking and health controversy. We believe it will be well received by those people who object to tobacco smoke." No one responsible for protecting the public's health or welfare has any knowledge or control over what chemicals have been or will be included in the so-called flavoring capsules. We believe that the FDA has authority to take jurisdiction against products like this. Despite the fact that cigarettes contain nicotine, are designed to have their byproduct inhaled into the bodies of consumers, and have not explicitly been excluded from coverage by the FDA, historically the FDA has not chosen to assert jurisdiction over traditional tobacco products which are sold for smoking pleasure only. However, the FDA has and should assert jurisdiction over tobacco products when health claims are made for these products or they otherwise meet the definitional standards of drugs under the Act. The legislative history of the Food, Drug, and Cosmetic Act clearly shows that Congress intended the definition of the term drug to be broad and not to be mutually exclusive. United States versus 46 cartons of Fairfax cigarettes, a 1950 case, which remains the law today, is instructive. In that case, the particular cigarettes were being marketed with a suggestion that they were effective in preventing certain diseases. The manufacturer contended that the cigarettes were being sold only to increase one's smoking pleasure, not unlike the same kind of specious claims we hear from the industry today. The court saw through the charade. As the court saw the issue, the question was whether the public, having in the mind the specious statements of the leaflets, would buy these cigarettes for smoking pleasure or with the hope of mitigating or curing disease. In conclusion, Mr. Chairman, let me make 2 points. We think that the information that has been presented so far this morning and will be presented leads to 2 inescapable conclusions. First, that the Food and Drug Administration already has sufficient legal authority and power to regulate cigarettes which make and imply health claims, and also the new alternative nicotine delivery systems. The failure of the Food and Drug Administration to assert this authority will inevitably and unnecessarily further jeopardize the health and safety of the American public. And 2,
you're reading from your statement, that statement's going to be in the record.
Okay.
We have to move on. Thank you very much. Mr. Schultz?
Thank you, Mr. Chairman. I was asked to testify on the question of whether R.J. Reynolds' new tobacco product could be classified as a drug within the meaning of the Food, Drug, and Cosmetic Act. As the subcommittee well knows, traditional tobacco products have not been subject to the jurisdiction of the Food and Drug Administration, either as foods or as drugs. And there are really two main reasons for this. One is a historical reason. Congress historically treated tobacco separately, and the FDA has concluded that historically Congress did not intend traditional cigarettes to be regulated as drugs or foods by the FDA. But the second reason is equally important, and that is the FDA has made this decision as a matter of its discretion. There are a wide range of decisions or options that the FDA can choose on a variety of issues, and where either option would be upheld by the courts. I cited the principal case that I can't emphasize enough. Even in the famous Action on Smoking and Health case, where the FDA was asked to regulate all cigarettes as drugs, when the agency's decision not to do so was reviewed by the court didn't conclude, as many seem to think, that cigarettes are not drugs. That's not what it said. What the court said is the FDA has a lot of discretion in this area, and we don't think it's abused its discretion. Now, there are two basic theories on which the FDA could regulate R.J. Reynolds' new product. And I want to emphasize that these are separate, and if the agency were to reach either conclusion, that would be sufficient to justify regulation. The first one is the agency could conclude that this is simply not a conventional cigarette. I included a diagram of the product in my testimony. I believe there's a diagram also included in the written testimony of the witness for R.J. Reynolds. But the diagram shows, I think to anybody looking at it, that this is a very different product from a conventional cigarette. It's a lot more complicated. It has various filters. It has a flavor capsule. The tobacco doesn't burn, and so on. It looks like a cigarette on the outside, but it looks very little like a cigarette on the inside. Based on that, the FDA concluded that this is not the traditional kind of cigarette that Congress intended to exempt, and therefore it could classify the product as a drug subject to regulation under the statute. The second theory is quite different. Even if the FDA, even if this were a traditional cigarette, the agency still has to look at the question of whether R.J. Reynolds is making health claims. The closest example is 20 years ago, a company tried to sell cigarettes as a weight-reducing agent, and it advertised, you take this product and you can lose weight. The FDA said, well, when you make that kind of claim, that turns your cigarette into a drug. It prohibited the product and was upheld in court. Here, R.J. Reynolds has walked a tightrope between cigarette and drug, and I think a look at its press release and other materials shows that it, in fact, it really has made health claims for its product. One of the comments by the chairman was read by the previous witness, so I won't repeat it, but on pages 1 to 2 of the addendum to our testimony, we've collected the various places where R.J. Reynolds has said something to the effect of, we believe that this product addresses the health concerns of tobacco consumers. And there's even one place where an attorney for R.J. Reynolds in a meeting with federal government officials explicitly stated that this product should provide important health benefits by reducing the risk of cancer in smokers. So it's quite clear, I think, to any observer that the reason the company is marketing this product is because it believes people may buy it because they think it's safer. And that is a justification, could provide a justification for FDA regulation. Equally important is the perception, how others, the press and others, have interpreted R.J. Reynolds' statement. And we've collected quotations from the Washington Post, the Wall Street Journal, and the New York Times on the last page, 2 pages of our addendum, but I think they show that the statements have been interpreted just as R.J. Reynolds intended. I have made some other points in my prepared testimony, but I see that my time is up, and so I'll conclude my oral statement.
Thank you very much, Mr. Schultz. Dr. Conley?
Thank you, Mr. Waxman.
And pull it right over to you.
My name is Gregory Conley. I'm Director of the Office for Non-Smoking and Health of the Massachusetts Department of Public Health. I'm representing the American Public Health Association, which is a co-petitioner with the AMA and the American Dental Association to require regulation by FDA of the smokeless tobacco product. I'd like to go back to history a bit with tobacco products. When FDA was first established in 1906, tobacco was used primarily by adult males who chewed tobacco, smoked cigars, and dipped snuff. The cigarette was new. It came in a few years earlier and was primarily popular with adolescent boys. In fact, in 1906, 6 states had banned the cigarette because of the high use by boys. The exemption allowed the industry to proactively introduce new forms of tobacco and new products without regulation. I think your predecessors here in 1906 would never have dreamed that this product, the RJR smokeless cigarette, this high-tech nicotine delivery device, would be allowed in the market without proper safety and efficacy testing. Well, the industry used the exemption first to bring in the Camel cigarette, and after 70 years it's still killing, not smoking. And this was the ideal product for deep inhalation. People could inhale this, particularly females. This allowed the spread of the smoking epidemic to females. After that, we brought in the filtered cigarette. I have an ad here for the Kent filter, which much like 35 years ago, I'm sure the manufacturer said, this is our new miracle filter. And it says here for health protection. Well, one of the tragedies about the Kent filter, it had something called asbestos in it. And Massachusetts, unfortunately, had the asbestos plant in our state. And we just finished a cohort study of the 35 workers in the Kent micronite filter plant. 29 are dead. 4 are suffering from asbestosis. And there are 13 billion filtered with asbestos cigarettes sold in the United States of America. We have no idea where those millions of consumers are today relative to their health effects. If we had tested the filter in 1954 for safety and efficacy, we could have saved many of those men and other people. Then we brought in the light cigarette, when we found out that filters didn't work. And the light cigarette supposedly reduced risk to heart disease, cancer, and stroke. I just want to talk about hypocrisy. This is a package of lights, not from the United States, but from the Philippines. And the tar and nicotine content in this product is twice that sold in the same lights in the United States of America. It's hypocrisy they're selling overseas, and it's hypocrisy they're doing today. Finally, we realized there was no safe form of tobacco. What did the industry do? They brought back smokeless tobacco because we know the cigarette wasn't safe. And at this time, used the exemption to develop a high-tech nicotine delivery device called the Skull Bandit. Good American know-how was used to drop the nicotine content from 14 milligrams to 4 milligrams to allow dependence to occur among young people. And could I have that chart with the effects of that marketing program? If you look at the chart in 1970, the highest use rates were adult males. We can tolerate that. They can die off, and we're not worried. But after 15 years of good marketing by the industry, using the exemption to develop specific products as part of a graduation strategy where these people were pushed up over time to higher nicotine brands, we had an epidemic of use among our young people. The new products we have is the RJR smokeless cigarette. Believe me, this looks like an 18-speed bike compared to this product. This is like a tricycle for teenagers. When the teenagers in America get a hold of this product, that chart is going to go off the board. What are our concerns with this product? Well, if you ask RJR what's in it, they tell you, according to this chart, a lot of tobacco in a small flavor capsule. Well, I really have a hard time buying that, so I took an X-ray of the product and looked inside. And can I have the next slide, next chart, please? And according to that, you've got a much larger flavor capsule than what we see in this chart here. And in this product, they apparently forgot to put the tobacco in. And what do we have? We have a carbon fuel element at one end, which is ignited, with some high-tech rods that go into a flavor capsule that looks like a set of BBs. It looks like something James Bond would use when he wants to kill one of his foes. And these BBs then blow in the back of his head. But these are flavor crystals. And the product has a flavoring agent, which RJR calls nicotine. Well, what's going to prevent RJR from taking the flavoring agent nicotine and putting in Nabisco shredded wheat in a few years and having compulsive breakfast eaters? There's little tobacco in that product. It's only there for regulatory exemption. It's a Rube Goldberg approach to give Americans nicotine, but more importantly, to give RJR an exemption from appropriate health and safety testing. We're concerned with this product because it still delivers carbon monoxide to users. RJR is not going to test the effects of carbon monoxide. We're concerned because this will be available to kids in this country in the convenience stores of America, where they can pick it up and become dependent upon nicotine. We're concerned because many smokers who may want to quit will see this as a cheap cessation device but only be hooked on it. And I would conclude, Mr. Waxman, with saying that if this goes on the marketplace, the adult smoker will probably suffer. But who will lose the most but the American child? We have 75 million Americans in this country today, children below age 20. Based on current smoking rates, 25 million will take up the practice and 5 million will be killed by the cigarette. On their behalf, I would request FDA to act on this petition. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. I'm a physician who treats addictive diseases, and I also teach others how to treat them as well, and my special interests are alcoholism and nicotine addiction. I'd like to, in my few minutes, provide a clinical dimension to what Dr. Koop and Dr. Henningfield have said about nicotine addiction, and then finally share my profound concerns as a clinician and as a public health worker about the R.J. Reynolds nicotine inhaler. Nicotine addiction is the most common serious medical condition in the country. If you figure that more than a quarter of adults smoke and about 1,000 people a day die from nicotine complications of nicotine addiction, it's also primarily a pediatric disease. 9 out of 10 adult smokers start in their childhood or adolescence. The average age of first cigarette is age 13, and in New Jersey, about 20% of high school seniors smoke every day, and another 20% smoke less than every day. 70% of teenagers who smoke want to quit, exactly like the adults who smoke would like to quit. Quitting involves a dynamic tension between the processes of thinking about not smoking and the processes of thinking about the things that are good and enjoyable about smoking. It's not a straightforward decision that someone wakes up one morning and says, I don't want to smoke anymore, although that's the way many people remember it. The cigarette companies know that there's a major dilemma about whether to smoke or not to smoke, even though their advertising is supposedly only directed at choosing a brand. An advertisement for R.J. Reynolds' product 12 years ago called Vantage says to smoke or not to smoke. Or the second ad that I have from Vantage has a similar message. It says, how many times have you decided to give up smoking? And pretty clearly the ad is directed at people who are trying or thinking about quitting. I've given to the staff copies of this book called If Only I Could Quit, which contain 24 personal stories of recovery from nicotine addiction. And these 24 individuals describe the ways in which they were trapped by smoking and what it took for them, after trying time and again, to finally stop, and what their lives have been like after they've stopped. The Surgeon General's report had as one of its recommendations that new nicotine delivery systems should be evaluated for their toxic and addictive effects. The next chart shows a drawing of this product, as Dr. Connolly described, and you see the carbon fuel element, the piece of charcoal leading to the aluminum chamber that contains a mixture of glycerin and nicotine that people can inhale this glycerin nicotine solution. R.J. Reynolds has been very close-mouthed about the exact data of results of this. They published a series of abstracts at the Society of Toxicology in February. The next chart shows some of their data in rats, comparing rats inhaling cigarette smoke versus rats inhaling aerosol. And you see that the rats inhaling the aerosol continue to breathe just as well as rats not just breathing regular room air, but those with cigarette smoke cut down on their breathing because they're irritated by the smoke. The next chart shows the nicotine levels in rats in the same apparatus, comparing, no, you took 2 off. Comparing the nicotine levels, and the nicotine levels in cigarette smoking rats are much lower than the nicotine levels in the rats exposed to the aerosol, suggesting that this is a much more efficient way to get nicotine in the body and may well prove to be the most addictive form of nicotine ever developed. The next chart outlines the major problems I see from this device, the first is just what I've said, that this may well be the most addictive form of nicotine ever devised. The second, that this inhaler will be attractive to novice smokers. It will look and appear safe, it'll be high-tech, it'll be a neat thing to try out, and very likely lead a lot of them to continue to use. Third, the inhaler will make abstinence less attractive for smokers. It'll make it less likely that people will decide to quit. Rather, they'll shift over to this device. Fourth, clean air rules are designed to help non-smokers protect themselves from tobacco smoke pollution, but a lot of people who smoke take advantage of those to stop smoking themselves. Such an inhaler will make, if it's used in non-smoking areas, will make it less easy for people to take advantage of clean air rules to stop smoking themselves when that's what they want to do. Fifth, 3 more points, please.
You better do it in 1 minute.
Okay. The inhaler may promote relapse to active nicotine dependence among people who used to smoke and see this as an attractive way to get back into using. Sixth, the inhaler will deliver nicotine and carbon monoxide. The Surgeon General's report outlines the ways in which nicotine itself is dangerous as a producer of chronic disease, and carbon monoxide with nicotine are suspected of being the major components that produce heart disease and that produce maternal fetal damage in the pregnant woman. And finally, the inhaler potentially is user modifiable to deliver other drugs, although nobody outside of R.J. Reynolds has examples of the product to look at themselves. Thank you very much.
Thank you, Dr. Slade. Start the questioning. I want to recognize Mr. Scheuer.
Thank you, Mr. Chairman. Dr. Conley, did I understand you correctly to say that of the youth cohort in our country of roughly 25 million people, that 5 million of them are going to die of cigarettes?
There are 75 million persons alive in the United States today below age 20. Based on high schools...
How many million?
75 million below age 20.
75 million.
Based on current smoking prevalence rates among high school students as reported by NIDA, we would expect 25 million to take up cigarette smoking. Based on that and current deaths from smoking, we would expect 5 million to be killed by the cigarette, far more than will ever be killed by AIDS, cocaine, heroin combined.
And you're saying that 20% of those who take up smoking will die from smoking?
Correct. Some data would suggest 1 out of 4 smokers, possibly somewhat higher, will be killed by cigarette smoking.
Well, that's a staggering figure. It's a horrifying figure. As you know, we have required all kinds of warnings. I won't give you the whole history of the warnings. Congressman Waxman had some legislation a couple of years ago that changed the warnings because people were getting sort of accustomed to them. So now we rotate the warnings. Has all of this accomplished anything? And if not, what is there, and I would open this up to any of the members of the panel, what can our society do to bring this appalling statistical probability to the attention of the 25 million young people, 25 of the 75 million young people among us who smoke, particularly in view of the several billion dollars a year that the tobacco companies spend in advertising, and particularly in view of the fact that young girls seem to be the only cohort in our society, the only demographic group that is increasing its smoking. What do we do to address the young people, and particularly young girls?
Can I just make 3 brief comments? Number 1, every time our educational efforts catch up with traditional tobacco products, the industry just brings in something new and does an end run. So unless we regulate new products, we're going to be losing this battle in the year 2010. For current products, I think we have to restrict marketing more in a drug model. That is, cut back on direct marketing to consumer. We don't allow Emprint to be marketed directly to the consumer. Cut down on free access by free distribution vending machines. Treat it more like a drug. So for the current products, don't ban them, but treat their marketing more in a drug model. For new products, don't let them in.
Yes.
I have a couple of modest proposals.
Yeah, make them quick because I want to hear also from...
There's no information available to consumers about what it is in tobacco, what the 4,000 substances are, that cause cancer and other diseases. Congress could certainly make that kind of information available, and it might impress people. Secondly, people ought to have a chance. One of my concerns is that those who want to quit smoking will, instead of quitting, turn to a product such as this because they are misled into thinking it's safer. And if there's any doubt that the FDA has authority to exercise jurisdiction over this product, Congress ought to give the agency authority to exercise jurisdiction over products where companies are making these kinds of relative health claims.
Dr. Slade.
Thank you, sir. I'm part of a commission on smoking or health which has a set of recommendations about children and tobacco, and I've shared that with the committee staff, and let me make 3 points from that. First, our schools, including teachers' lounges, need to be smoke-free. There are signs all around our schools in New Jersey saying drug-free school zone, but that's only true for the 3 or 4 school districts which are smoke-free. Second, when we talk about drugs and alcohol, nicotine has to be one of the drugs that we talk about up front as part of the agenda on drugs and alcohol for all children. And third, you mentioned the tobacco industry's advertising and marketing budgets. They spend about 6 cents a pack on marketing. It would not be difficult for the federal government and state governments to impose excise taxes vote equivalent of 6 cents a pack on counter-marketing. This approach is being tried in Minnesota and in a number of countries around the world, and is a most effective means of controlling this epidemic.
Thank you, Mr. Chairman.
Thank you, Mr. Short. Mr. Whitaker?
Thank you, Mr. Chairman. Mr. Ballin, do you think that FDA has the authority to regulate all tobacco products if it really wanted to, or do you think that legislation is needed to specify and clarify FDA's authority over tobacco products?
The Coalition's view is that we believe the FDA does have the authority to regulate tobacco products that do make health claims, and we have filed petitions with the FDA on not only the RJR product, but also low-tar, low-nicotine products as well. With respect to the second part of your question, I think that legislation needs to be enacted that will regulate all tobacco products in the same way we regulate prescription drugs, both in the manufacture of those products, the sale of those products, the distribution, the advertising, and the promotion.
Dr. Slade, your written testimony indicates concern over the scientific community's access to details and data on the R.J. Reynolds' new product. Yet, in Mr. Cooper's statement representing R.J. Reynolds, he states just the opposite. Could you comment?
Certainly. To my knowledge, R.J. Reynolds has made 2 attempts to communicate to the scientific community about its cigarette. One was at a series of abstracts presented at the Society of Toxicology in Texas in February at a poster session originally designed for graduate student work. Poster sessions are not fora for discussion. By definition, it's a one-on-one kind of affair, and you don't get an interchange. And it is not a peer-reviewed sort of submission. The other communication I'm aware of are invitation-only symposia for which R.J. Reynolds pays travel expenses and gives a $750 honorarium to all participants. At these symposia, I have heard a rumor that R.J. Reynolds discusses the ways in which this product in short-term tests looks like an agent that doesn't cause cancer, but I've heard nothing about any information that addresses the concerns I brought to the committee today.
Mr. Ballin, given the health concerns about cigarettes and their addictive properties, doesn't it make sense to develop a safer cigarette for those individuals who are either unable to give up tobacco entirely or do not wish to?
It may make sense, but do we know, in fact, that these products are, in fact, safer? We don't know anything about these products, and that's the concern that our organizations have. That's why we think that some federal agency, be it the FDA or any other agency, needs to be looking at these products and subjecting them to the tests as we do with our foods and drugs.
Okay. And further, from your testimony, I assume that you strongly support the objective of a smoke-free society by the year 2000. In your opinion, Mr. Ballin, how are we progressing on achieving that goal, and how should the federal government participate?
I think there is a major change in the attitudes among smokers and non-smokers in this country, and they're becoming more aware of the dangers of cigarette smoking. I think the Surgeon General's report on nicotine addiction has brought the seriousness of this product to the attention of the American public. I think now we need to start focusing our attention on the policy implications and how we go about ensuring that this product is in fact regulated as a drug, which the Surgeon General has branded it. And that includes such things as ensuring that minors don't have access to the products, either through vending machines or free sampling, or restricting or prohibiting advertising. We don't allow prescription drugs to be advertised because it would be drug pushing. But in fact, tobacco is an addictive drug, and in fact, the advertising promotional activities of the industry is tantamount to drug pushing. And I think we need to really seriously focus in on some of those activities.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Whitaker. Mr. Bruce?
Thank you. Mr. Schultz, on page 4 of your statement, you say that action on smoking and health versus Harris held that the FDA has the discretion to exempt traditional cigarettes from its jurisdiction. It's a quote out of your testimony. Isn't it a fact that there was no discretion involved in that case?
I read the opinion fairly carefully, and the court held that the FDA's action was not arbitrary and capricious, and it talked quite a bit about how this was a matter for the FDA to determine and use its scientific judgment and so on. And I read that as the court as saying that the FDA has the discretion here. The court did not
in
really
the petition, did
go
not
further.
the FDA hold as a legal matter that it had no jurisdiction to assert, and that in the absence of a therapeutic claim by cigarettes, that they held that they could not, wasn't discretion, they had no legal authority, and didn't the court uphold that legal determination? It wasn't a discretionary question. It was, they said they did not have jurisdiction.
You may be correct in terms of what the FDA said, but in terms of what the court said this was a matter within the FDA's discretion. I also think that in other contexts, the FDA has made it clear that health claims are not essential to classifying a product within its regulation. This product Favor, which was something that looked like a cigarette but basically gave you a shot of nicotine, I don't believe the company there made any health claims, yet the FDA classified the product as a drug subject to regulation. I think it's useful to consider, what if this product caused 10 times the health problems of traditional cigarettes, 10 times the cancer, 10 times the heart disease, and so on? Surely the FDA there would have the authority to regulate, and I think the type of analysis is the same.
All right. The fact is, in action on smoking and tobacco versus Harris, court held that there was no legal basis and it wasn't discretionary. On page 5 of your statement, you have a diagram of the new product, and you refer to the capsule as a, I guess the company refers to it as a flavor capsule. You say it's a nicotine capsule. I take it you assume that nicotine is added to the capsule?
Well, I realize that there are some discrepancies, not just between my testimony and the company's testimony, but if you look through the various submissions in the record, various people say the capsule has nicotine. Some people say it just has flavoring components. I don't think it really matters. The point is, we don't know what's going to be in the capsule, and one of the reasons that the FDA ought to evaluate this question, or that some agency ought to evaluate it, is so that we do find out what will be in the product and an evaluation of its safety is done.
Mr. Schultz, let me ask you, do you think that cigarette companies ought to try to develop a safer cigarette? A cigarette that has less nicotine, tar?
I think that may be appropriate, yes.
Okay. I think that's kind of basic to what we're going to be talking about.
Well, I'll tell you why I hesitate, because I think the best thing is for people to stop smoking, and I think in some sense it would be a shame if people who are going to stop smoking switch to a dangerous but less dangerous cigarette. On the other hand, if people who smoke are going to switch, then that's in the interest of the public health. But my point, I haven't said anything about whether this product ought to be approved. My whole point is it ought to be evaluated. Some agency, and the FDA is the appropriate one here, ought to make the determination as to whether, in fact, the product is safer.
Okay. Following up on that, Dr. Conley, I notice in your testimony you state that Reynolds cigarette, and I quote, has been intentionally designed to prevent cancers associated with smoking conventional cigarettes. And I was just curious, if that is their goal, as a public health official, don't you think that would be a wise alternative to the people who are going to smoke? And
Well,
what is bad about a cigarette company developing a product, according to your own quotation, that would prevent cancer associated with smoking?
Given the fact that we have more deaths from heart attack than we do from lung cancer, it's like jumping from the 7th floor rather than the 10th floor. I think if RJR can reduce the cancer risk, why not put it to the company to reduce the carbon monoxide risk? And do it publicly, and do it through a regulatory agency, and then allow access of that product to come through a pharmacy as a smoking cessation device. Conceivably, this product could come in place, and we could go from 33% of the adult population using nicotine to 80% in 3 or 4 years. I think we should regulate it.
I'm told that this cigarette that's proposed would reduce nicotine intake by 92%, and your carbon monoxide question reduces it by 72%. Having done that, would you not say that it would be better for a smoker to convert or change or whatever to a cigarette that reduces nicotine by 92% and carbon monoxide by 72%?
Well, I'm happy the industry's talking with you. I wish they'd give me the same data and let me take a look at it, or let our health department take a look at it, number one. Number two...
If that is true, if it does reduce nicotine by 92% and carbon monoxide by 72%, why would you want to keep that product off the market?
Oh, I'm not saying that at all.
Okay.
Due process, number one. Number two, if a person's addicted or hooked to the product, let them have it, but through a drug model. Let them go through a pharmacy and buy it at a pharmacy. Don't put it in the convenience stores of America where the 15-year-old kids can pick this thing up and become dependent on nicotine. History shows that. History has shown us that the industry has used these exemptions to hook each generation of children on their products.
But, Doctor, if we took your paradigm and we say, let's regulate this as a drug, we put it behind the counter, and then we continue to market cigarettes, aren't you concerned at all as a public health official that you've committed more children to smoking the product that you find worse and restricting the access to a product that you and I would admit, if it reduces nicotine by 92 and carbon monoxide by 72, you restrict it to where they can't get access to it? I mean, why would you want to do that?
We are winning...
Yeah, thank you, Mr. Chairman, for allowing me to...
We are winning the battle with cigarette smoking in this country. That's why that product is up there. If we were not winning the battle against cigarette smoking, that product wouldn't be there today. And what are we doing? We're going to allow them to bring in now this new device to circumvent everything we've done to curb smoking today. If we've got any intelligence, any concern about the children alive today in this nation, we've got to say to this product, we're going to control it the way we should have controlled the cigarette in 1906. Allow access, yes, through a drug model, but not let them introduce this as their new high-tech cigarette to replace the old ones.
Okay. Thank you, Mr. Chairman, for your allowing me to follow up on that last question.
Mr. Bliley?
Thank you, Mr. Chairman. Dr. Slade, on page 10 of your statement, you point out that RJR told the Society of Toxicology that rats exposed to smoke of the new cigarette had higher nicotine levels in their blood than rats exposed to the smoke of the reference cigarette. Isn't it true that in the same RJR presentation to the Society there was a study showing that humans had lower nicotine in their blood from the new cigarette than from the reference cigarette?
I have seen no human data on the new R.J. Reynolds product.
I see. On page 13 of your written statement, you state that while the new Reynolds cigarette might reduce the risk of lung cancer from cigarette smoking, it should be regulated because it contains carbon monoxide and nicotine, which you state cause heart disease. It seems to me that reducing lung cancer should be enough, but if it isn't, I am advised that Reynolds cigarettes, as my colleague just pointed out, contains less nicotine than 97% of the cigarettes currently sold and less carbon monoxide than 72% of the cigarettes currently sold. Seems to me these are significant gains, and I do not understand why you wish to deny the alternative to the American public.
Mr. Bliley, let me explain something that's gone into in great detail in the Surgeon General's report. The FTC smoking machine, on which your figures are apparently based, smokes cigarettes in a way entirely different from the way human beings smoke cigarettes. People regulate their nicotine intake so that there's not any difference at all in the nicotine blood levels of somebody smoking an unfiltered Camel and somebody smoking a Camel Light, in spite of the fact that the rated nicotine levels are very different. If this product is a commercial success, it will contain and deliver addicting doses of nicotine. Low nicotine-containing products have been tried repeatedly since the 1950s and have not succeeded in the marketplace.
Well, it may be or may not be. They're spending an awful lot of money on it, and they seem to think it'll work. And I suppose, you know, depending on what the FDA does, we may know or we may never know. Moving on, and since my time is limited, Dr. Connolly, on page 5 of your testimony, you indicate that the flavor capsule contains nicotine. Am I to assume that you mean that nicotine is added to the capsule?
According to their patent, there's a couple of designs they've talked about. One is adding nicotine to the glycerin in the flavor capsule. Another one is sprinkling nicotine on tobacco leaf inside the jacket, or washing the tobacco leaf with nicotine to increase the dose. So there's all kinds of stuff going around here. Again, I think a couple of people know more than the scientists know about this product, the independent community. I'd ask RJR to present that data to FDA for review. But we don't know. And they may design the product tomorrow or the next day, and we don't know. We don't know what nicotine levels may be in that product 6 months from now. This may be just the foot in the door. They may add something else to the capsule a year from now. We don't know. The way they put asbestos in the micronite filter 35 years ago.
My time is limited, and you had your 5 minutes. Let me get on with my questions. On page 6, you say that the nicotine in the product is not derived from the tobacco leaf contained in the product. What is your basis for saying that?
My understanding is that they're taking a tobacco extract, and again, my understanding is it could be from the leaf or it could be from nicotine crystallines. We don't know. I looked at the patent. I've looked both at their international patent and U.S. patent, and again, the problem I have is they call nicotine a flavoring agent.
If you are mistaken then in your two assertions, does that change your view of the product?
No. I mean, you could wring coca, you know, from the coca plant. You could take cocaine out. And if the coca plant was legal, I don't think we'd allow the sale of cocaine in this country just because we extract nicotine from the tobacco leaf. We can't misclassify nicotine then as tobacco. It no longer becomes tobacco when it's extracted. It's a chemical called nicotine, according to the Surgeon General's report.
Are you saying that we should make tobacco illegal in the United States?
Not at all. As I stated, for new products, don't let this industry do an end run using an exemption from regulatory authority to hook the next generation of kids on nicotine. The new products, we have to take a hard line on. The current products, my opinion is they should remain legal, but we should restrict their marketing more in a drug model based on the findings of the Surgeon General's report.
Well, do you feel that the tobacco industry has any responsibility to try to make a safer cigarette?
They do, but based on history, they haven't done it.
Well, if you don't give them a chance, they may never do it.
We have given them 70 years, since 1906, or 80 years now, to come up with a safer product. And they've still got Camel out there killing. They've brought in, and I showed you these low-tar, low-nicotine brands. They hypocritically go into the Far East, and they say, here's RJR Winston Light with twice the nicotine sold in the U.S., twice the tar. Do we trust that industry? They developed the Skull Bandit. They use high technology to develop it as part of a graduation strategy. Then they send representatives onto college campuses to get kids to experiment with the low nicotine product. And the graduation strategy calls for them to go from low nicotine to the Copenhagen, the high dose over time. It's called corporate addiction. They know how to get people hooked onto nicotine better than any drug dealer in this country.
Gentleman's time has expired. Chair recognizes himself. Dr. Conley, is there any evidence that you're aware of that cigarettes could be marketed without nicotine, or is nicotine essential to the success of smoking?
According to the Surgeon General's report, again, nicotine is the essential chemical for tobacco use. Without nicotine, people will not smoke.
Why not?
The chemical nicotine produces behavioral effects on the user, effects on the central nervous system that create dependence. The person then would crave the nicotine and inject that to himself over time in a very orderly fashion once dependent.
So if we just had some other kind of cigarette without nicotine, if they could reduce the nicotine, Why wouldn't people just use that and try to insofar as they want to smoke? In other words, are you telling us that nicotine is essential because in order for people to continue to smoke, that has to be addictive?
Absolutely. You have to administer the nicotine to your system once dependent over time in regular doses during the day.
Now we're looking at a potential new device for transmitting nicotine, which may or may not be a cigarette. We've had some devices that are used to convey nicotine, and those have been clearly determined to be drugs, and FDA has had the authority and responsibility to review them, and people who use those products have had to get prescriptions for them. The new product that R.J. Reynolds is proposing is what they claim a cigarette and therefore not subject to regulation, as opposed to a nicotine device, transmission device. Mr. Schultz, they claim from R.J. Reynolds that their promotional material won't argue that it's any safety or health claims, and that it really, because it contains tobacco, is a cigarette and shouldn't be regulated like a cigarette, or really should be treated like a cigarette and therefore not regulated. Do you believe the average consumer or the FDA could reasonably construe the concept of a cleaner or smokeless cigarette to imply a health claim about reducing the risk of cancer or the diseases?
Yes, and I think it's quite clear that that's what the company hopes people will assume. In addition, they've gone beyond that and have used the word health and have talked about how their product addresses the health concerns of consumers. I think they want people to assume that this product is safer, otherwise they wouldn't have any competitive edge with it.
So the very purpose of their product is to try to market it as something that's safer, but they don't want an FDA review as to the safety medically or effectiveness of this product the way we would any other product that made these health claims. Is that your position?
That's my view. It is interesting and I think significant that the patent apparently listed tobacco as optional. If tobacco weren't in the product, I don't know that we'd be here. I don't know that there'd be much question.
In other words, if they didn't have any kind of trace of tobacco in the product, there's no doubt that it would be considered reviewable by the Food and Drug Administration under present law.
Well, that's my view because the FDA did exactly that for another product called this flavor smokeless cigarette. It was a product that looked like a cigarette that had nicotine but no tobacco, and the FDA did take that product within its jurisdiction.
Dr. Slade, the RJR company indicates that they're submitting the results of their research to peer-reviewed scientific journals. I want to know from you, is this true? Have any reports been accepted to your knowledge? And could you tell us whether any of their published research is available on the product's long-term chronic health effects or effect on the cardiovascular system?
I'm not aware of any peer-reviewed publications relating to the R.J. Reynolds product. I'm delighted to hear that there's some that have been submitted. There has not been time for them to do long-term health effects research on this product. And getting back to a question that I was asked earlier about human blood levels of nicotine, I would wonder if the studies in which human levels of nicotine were assessed with this nicotine delivery system were subjected to ordinary human studies protocols for approval before they were done.
You have no information?
I have no information.
Does anyone else on the panel have information about that? Well, we'll hear from other witnesses in a short time. Maybe we can get some responses to it. I appreciate the testimony you've given. Members may wish to submit written... Yes, Mr. Bruce, do you want another round of questions?
One thing Dr. Slade has mentioned and you brought up in questioning, RJRN, as I understand it, made a presentation to the Society of Toxicology. You referred to that. It is my understanding in that presentation that they also talked about nicotine levels in human blood after smoking and compared it to reference cigarette. Now, you said that in your testimony you didn't know about that. Mr. Waxman has followed up with a question. What I'd like to know is, did you read the full presentation made to the Society of Toxicology, and was there any reference in that study to the nicotine level in the rat blood and the nicotine level in the blood of humans? That's all I need to know.
There were 11 abstracts presented in a poster session. All I have been able to see are the abstracts themselves, and none of the abstracts I reviewed talked about human studies.
Okay, thank you. That clears up the question then.
We may have written questions from members of the subcommittee to you. For the record, we'd appreciate if you would respond to those questions, and I thank you very much for being here this morning.
Thank you.
Our final witnesses represent the RJR Nabisco Company and the Tobacco Institute. Richard Cooper is a Washington attorney representing the RJR Nabisco Company. Charles Whitley is a consultant to the Tobacco Institute. Mr. Whitley is accompanied by Theodore Blau, a clinical psychologist from Tampa, Florida, and Stephen Raffel, assistant professor of psychiatry at the University of California at San Francisco. And is Neil? Without objection, your prepared statements will be in the record in full. What we'd like to ask of you is a oral presentation to us of no more than 5 minutes, and we'll start with Mr. Cooper.
Mr. Chairman, my name is Richard Cooper. I'm a partner in the law
firm.
Pull
the microphone. Be sure it's on, and then pull it closer. There's a little button on the base.
Thank you, Mr. Chairman. My name is Richard Cooper. I'm a partner in the law firm of Williams & Connolly here in Washington, D.C. I am happy to appear here today as counsel for R.J. Reynolds Tobacco Company to address the legal issues raised by the question put in the notice for this hearing concerning the nature and extent of the Food and Drug Administration's authority to regulate nicotine-containing products such as the so-called smokeless cigarette. All of the facts that I will rely on in my testimony have already been put in the public domain by the company. R.J. Reynolds' new product, announced last September, is a cigarette, which will be marketed to adult smokers solely for their smoking taste and enjoyment. The cigarette contains tobacco, which is essential to its performance. It is lit at one end, and when the smoker draws on it, it produces smoke at the other end. The Surgeon General's comment that the product does not produce smoke that's inhaled is, with respect, incorrect. Thus, in its essential characteristics, this cigarette's function and purpose, its use of tobacco and production of smoke, it is just like any other cigarette. Like all cigarettes, this cigarette contains tobacco rolled in paper. At the tip is a highly refined carbon heat source, which is wrapped in an insulating jacket and paper. The heat source and a small amount of paper are the only parts that burn. Inside the cigarette, in addition to the tobacco, is a capsule with a small amount of added flavors and spray-dried tobacco extract, which is used in other cigarettes, and a tobacco paper filter. And the company has disclosed that the flavorings that are used here in the flavor capsule are 2 in number. One is a sugar, and one is an extract of a very common food. Those are the only flavorings added to the product. At the smoker's end is another filter made of polypropylene. The key difference between this cigarette and other cigarettes is that it heats but does not burn tobacco. Thus, this cigarette represents a significant advance in cigarette technology, which has been evolving since the 1950s, through such innovations as filters, porous cigarette paper, puffed tobacco, and reconstituted tobacco sheet. These advances have been made by Reynolds and other cigarette manufacturers in order to achieve lower yields of tar, nicotine, and other chemicals produced by burning tobacco in order to meet the demands of smokers. Reynolds' new cigarette reflects one more step in this continuing advance in cigarette technology. All of the nicotine in the new cigarette is naturally present in the 3 forms of tobacco in the cigarette. No nicotine is added. Reynolds has subjected the new cigarette to an extensive set of scientific tests in laboratory systems, animals, and humans. Reports of the methods and the results of that testing are being submitted currently to peer-reviewed scientific journals and are being presented in the scientific community before the cigarette is introduced to the market. Additional testing is underway and will be reported similarly as results become available. In its advertising and labeling of the new cigarette, Reynolds will make no therapeutic claims for it. It will not make any claim or representation that the cigarette is useful in the diagnosis, cure, mitigation, prevention, or treatment of disease. It will also not make any claim or representation that the new cigarette is safe or that it is safer than any other cigarette. On the contrary, precisely because it is a cigarette, the new cigarette and its advertising will bear the Surgeon General's warnings mandated by Congress for all cigarettes. And in addition, the new cigarette will be labeled, advertised, and marketed in conformity with the legal requirements and restrictions applicable to all cigarettes. And it will be taxed in the same way as all other cigarettes. I can sum up the relevant law, I believe, briefly. Whether the Food and Drug Administration has jurisdiction over this product as a drug or device depends on its intended use, and it is well-settled law that the intended use of a product such as this depends, in general, on the claims or representations made by the manufacturer. And as I have indicated, Reynolds will make no claims of a therapeutic nature for this product, and consequently, the Food and Drug Administration has no jurisdiction over it as a matter of law. Thank you, Mr. Chairman. I'll be happy to answer questions.
Mr. Cooper. Mr. Blau? Are you here to testify? Or, oh, Mr.
Mr. Chairman, I'd like to speak
Mr.
first
Whitley.
on behalf of the Tobacco Institute and introduce our other witnesses. With me today are Dr. Theodore Blau, a practicing clinical psychologist, and Stephen M. Raffel, M.D., a clinical psychiatrist and assistant clinical professor of psychiatry at the University of California School of Medicine at San Francisco. They will address the Surgeon General's assertion with respect to cigarettes and addiction from a clinical and scientific standpoint. Mr. Chairman, from an ordinary common sense standpoint, to call cigarette smoking an addiction trivializes and almost mocks the serious narcotic and other hard drug problem faced by our society. It's been mentioned earlier in testimony today that Dr. Coop, in an earlier statement, in all seriousness, said that 1982 young people are addicted to video games. The escalation of rhetoric in his latest report is similarly without medical or scientific foundation, as is attested to by the fact that 41 million Americans, and this is pointed out, Mr. Chairman, in the same report, that 41 million Americans have stopped smoking, more than 90% of them without any kind of outside help. There's no way you can come up with any comparable figures on hard drugs, the kind of drugs, heroin and cocaine, with which he has compared nicotine and smoking. Neither is there any justification, Mr. Chairman, for establishing any special regime of regulation of cigarettes by the Food and Drug Administration. The Food and Drug Administration has never treated cigarettes as exempt from regulation under the Federal Food and Drug and Cosmetic Act, but has asserted jurisdiction when health claims have been made by vendors or manufacturers, and this has been upheld by the courts. But to subject cigarettes to general FDA regulation in the absence of health claims would first of all impose substantial new burdens on an agency that's already overburdened. It would fragment its regulatory focus and divert scarce resources from such essential tasks as the approval of new medicines. It's been mentioned earlier, I think, in a question by Mr. Bliley, that the French Minister of Health, who is a vocal critic of the tobacco industry, referred to this latest Surgeon General's report in this language: tobacco cannot be compared to drugs, especially hard drugs like heroin or other narcotics. It's always bad to fight an evil with misstatements or distortions of the truth. Talk of addiction would mean comparing tobacco with something which completely alters the personality of the subjects, turning them into antisocial individuals, which we know is not the case with the overwhelming majority of smokers. In making these statements, he has echoed the conclusions of the National Institute of Drug Abuse and the American Psychiatric Association and the World Health Association. Dr. Charles Schuster, the head of the National Institute of Drug Abuse, has emphasized the big difference between tobacco and hard drugs in this language. When one smokes tobacco, it does not alter your behavior or function so you become dangerous or obnoxious or an embarrassment to society. Dr. Coop himself has acknowledged that the World Health Association decided a number of years ago to stop using the term addiction, having concluded that the term is so misunderstood and misused that it lacks any meaning. The American Psychiatric Association does not use the term either, presumably for the same reasons. Editorial writers across the country have also expressed immediate sharp disagreement with the Surgeon General's addiction report. The Boston Globe noted, "Smoking bears no resemblance to drug abuse or alcohol abuse. Smoking does not affect mental acuity, nor temporarily derange a person, nor produce so much as a lull in anyone's contact with reality." The Indianapolis Star said, "Classifying the dangers of nicotine with the horrors of heroin or cocaine is misguided zealotry. It downgrades, even discredits the nation's campaign against hard drugs. The Surgeon General's latest attack on smoking is itself generally irresponsible. His enthusiasm has turned to zealotry and is on its way to fanaticism." The Kansas City Star called the Surgeon General's contentions with respect to cigarette smoking and addiction ridiculous. None of these publications, Mr. Chairman, has demonstrated any love for the cigarette industry or for smoking. But they say that in classifying tobacco as addictive, that the Surgeon General is overreacting. Doctors Blau and Raffel will comment in detail on the medical and scientific aspects of the Surgeon General's report. But I would note in closing that if the use of heroin as an addiction, or stopping the use of heroin or cocaine is a measure of addiction, how difficult it is to stop, then the mere fact that people find it difficult is not enough. Then any behavior that people engage in on a regular basis could be considered an addiction. Mr. Chairman, this report is a political document. It started off with a conclusion and assembled everything it could to support that conclusion. It makes no effort to show any conflicting evidence of any kind. At this time, I yield on my left to Dr. Raffel.
Mr. Chairman, members of the committee, I'm Stephen Raffel, a physician who practices psychiatry in Oakland, California, and an assistant clinical professor of psychiatry at the University of California School of Medicine in San Francisco. I appear before you today in order to provide a perspective that's missing from the 1987 Surgeon General's report, the clinical perspective, which in my opinion runs counter to the conclusions that nicotine is addicting. Some of the clinical features and properties of addictive drugs are not, and I emphasize that, shared by cigarette smoking. The first of those is intoxication. A person on hard drugs is intoxicated. Intoxication is fundamentally an organic brain syndrome whereby the person's state of consciousness is altered, reasoning is impaired, coordination is affected, memory and concentration are substantially altered. Further, mood is visibly changed, judgment is impaired, delusions and/or hallucinations may occur, and unconsciousness or sudden death will result from a substantial overdose. Intoxication does not occur with cigarette smoking. The effect on mood and mental functioning of cigarette smoking is more akin to drinking coffee. Withdrawal. Abrupt cessation of hard drugs following regular use will inevitably and predictably result in a, quote, classic, unquote, withdrawal syndrome. This generally requires medical hospitalization for clinical management because drug withdrawal can be a life-threatening situation. The symptoms of withdrawal due to physiological dependence include severe vasomotor instability, muscle cramps and nausea, hallucinations and/or delusions, dangerous changes in body temperature, seizures, mood changes often accompanied by paranoia, and suicidal ideation and attempts. Death may even occur if the patient is hospitalized and properly medically managed. Cigarette smoking causes none of these signs or symptoms. It is impossible to predict whether or not a smoker will have any tobacco abstinence discomfort based on the number of cigarettes smoked per day or the duration of smoking. The most uncomfortable, complaining cigarette abstainer does not remotely resemble a person who is withdrawing from hard drugs. But, and in fact, the symptoms and complaints do resemble those of a dieter or other person giving up a well-liked habit or a close relationship. These people continue working while, quote, withdrawing, unquote, and continue to meet their responsibilities without significant disruption in reasoning, judgment, concentration, or efficiency. There are differences in socialization between hard drugs and tobacco. The pharmacologic effects of hard drugs lead to a lifestyle which is dominated by the drug. Family responsibilities are shirked, employment becomes unpredictable, morality is eroded, illegal activity is often resorted to in order to obtain the hard drug. Marital discord is usually evident. Abuse and the emotional scarring which results can last for generations. Cigarette smokers do not suffer these psychological and sociological impairments. They are not behaviorally dominated by a drug-induced state. In my experience, cigarette smokers are not different from the general run of normal, honest citizens. Cessation differences. For the hard drug user following detoxification and stabilization, a completely new lifestyle must be established. For many, it will be a lifelong undertaking requiring ongoing reinforcement. Since 1964, more than 35 million people have stopped smoking without any outside intervention or assistance. For the cigarette smoker, my clinical experience and numerous studies have demonstrated that the components of successful abstinence are commitment, personal responsibility, and self-efficacy. By self-efficacy, I mean a person reasonably believing he can accomplish an undertaking. As with successful dieting, the participant must abandon a pleasurable activity in order to obtain a greater long-term benefit. However, neither the dieter nor the smoker must rebuild his life to succeed. I have some additional observations in closing. The use of the word addiction to describe a particular behavior is emotionally charged and open to misuse. The Surgeon General's 1987 report has redefined it, largely within a pharmacological context, and used selected research to demonstrate that tobacco is addicting. However, his report ignores critical components of hard drug addiction, and in so doing renders that term meaningless and overbroad. A logical question flowing from the Surgeon General's report is whether an addiction label on tobacco products would motivate smokers to stop and prevent non-smokers from starting. This is my last point. Regarding smokers, it is easier to stop a habit which one believes is not an addiction, because one must then assume personal control and responsibility for his or her behavior. Quote, addiction, unquote, provides a convenient external excuse, an easy out, if you will, for not initiating abstention or for giving up too easily at the first sign of tobacco abstinence discomfort. Many individuals who want to continue smoking have already created the personal myth that they are addicted, thereby excusing themselves for not trying to stop. Endorsing that myth perpetuates and exacerbates this situation. They are now officially forgiven their failure.
Thank you very much, Mr. Raffel. You're reading that statement, and that's all going to be in the record. Appreciate it. Mr. Blau?
Thank you, Mr. Chairman. I appreciate the opportunity to appear before this distinguished committee. During the last 37 years, I've seen over 4,000 patients of all ages. Among the disorders I've treated are addictions to a variety of drugs. In addition to my clinical practice, I have assessed the merit of scientific research for various organizations, including the United States Army, Department of State, National Institutes of Education, various universities, law firms, and state agencies. I'm also a past president of the American Psychological Association, the scientific and professional organization of over 70,000 psychologists in the United States and Canada. A list of other positions I've held is appended to the statement. I'm here today in the hope that I can provide some clarity and resolution to the confusion created by such statements as smoking is addictive and nicotine and tobacco is as addictive as cocaine and heroin. These statements are misleading, and they are potentially harmful to the American public. The word addiction has been used widely and loosely to describe many habits and everyday behaviors such as coffee drinking, jogging, falling in love, cigarette smoking, and video game playing. My view of addiction is the view of a practicing clinician, and that's the basis of my remarks today. Addictive drugs cause intoxication when taken and significant withdrawal responses when given up. Taking an addictive drug causes major interference with thinking, with judgment. The drug addict, either when intoxicated or in the grip of withdrawal effects, cannot make reasoned decisions, including the decision to use or not to use the drug. On the other hand, smokers are always able to reason without interference from their habit. Smokers can make a personal decision to smoke or to stop smoking. The vast majority of those who have stopped smoking have done so with no help and little distress. When a drug addict gives up his or her drug by choice or by legal mandate in jail, a severe withdrawal syndrome is very likely to result. Some withdrawals result in convulsions, significant pain, body dysfunction, and in some cases, death. During this withdrawal phase and for months or even years afterwards, the former drug addict is often unable to think clearly or decisively in his or her own interest or within legal or social expectations. On the other hand, some smokers who decide to give up the smoking habit experience what amounts to a couple of days of mild irritation or irritability. Thinking is not distorted in those who give up smoking. Friendships, work, social activities remain essentially intact. Over the past 37 years, I've reviewed over 7,000 research articles relating to the subject of smoking and addiction. My evaluation of this research supports the following conclusions. First, the use of materials containing nicotine is not equivalent to the use of addictive drugs such as heroin and cocaine. The role of nicotine in tobacco smoking is much more like the role of caffeine in coffee drinking. Secondly, people can and do choose to stop smoking. The process of quitting the smoking habit is very different from giving up addictive drugs. Third, those who quit smoking on their own are more likely to continue to decide not to smoke than those who seek external help or prefer to use their habit, to view their habit as something they cannot control themselves. I wish to briefly address the Surgeon General's report and the statements made today by the Surgeon General and by Dr. Henningfield. They characterize smoking as an addiction equivalent to or worse than the use of drugs such as cocaine and heroin. These statements are misleading and unfortunate. The report is misleading for the following reasons. First, the report redefines addiction in its effort to include the smoking habit. Secondly, conclusions are based on poorly designed studies. And I have just a few more remarks. Third, the research interpretations which cast serious doubts on conclusions in the report are omitted, reinterpreted, or rejected. Finally, it's unfortunate that Dr. Koop trivializes drug addiction. This could do extensive harm to those who are working in real drug avoidance and efforts to stop the drug trade and to bring about treatment of the addictions. Labeling cigarettes as addictive could result in fewer people deciding to quit. Thank you, Mr. Chairman and members of the committee.
Thank you, Dr. Blau. Mr. Cooper, Commissioner Young has testified that the FDA must attempt to differentiate between the traditional tobacco product not regulated by FDA and newer innovations designed to deliver nicotine to satisfy a nicotine dependence or otherwise to affect the structure or function of the body. Do you agree that FDA has authority to differentiate between such products and has the statutory authority to regulate newer innovations designed to deliver nicotine to satisfy a nicotine dependence?
It depends, Mr. Chairman, on the nature of the innovation and the nature of the claims and representations that are made for it. The reasoning that underlies FDA's precedents relating to cigarettes and the judicial decisions relating to cigarettes are not limited to cigarettes. The reasoning applied in those instances were general principles of food and drug law that are applicable to a wide range of products. There's nothing peculiar or anomalous about the FDA's treatment of cigarettes, and in my view, the new Reynolds cigarette is a smoking article marketed for smoking pleasure.
You've already stated that, but you've already stated that, but I'm trying to. You've already stated your conclusion, but you do agree that under some circumstances, You try to differentiate those circumstances. FDA does have authority to regulate these newer devices to deliver nicotine.
Under some circumstances.
Okay. Now, you've testified that Reynolds has subjected the new cigarette to an extensive set of scientific tests in laboratory systems, animals, and humans. Reports of the methods and results of that testing are being submitted to peer-reviewed scientific journals and are being presented to the scientific community before the cigarette is introduced to the market. Additional testing is underway and will be reported similarly as results become available. That's on page 3 of your testimony. Does Reynolds hope to demonstrate the product's safety by conducting and disseminating the results of these tests?
No.
If RJR's scientific tests demonstrate that the product increases a smoker's risk of heart disease or cancer, will the company still bring the product to market?
That's a hypothetical that we needn't speculate on. I don't think it's present, as far as I'm aware. I'm not a scientist, as you know, Mr. Chairman.
No, but I'm asking what your client intends to do. Your client is doing tests. They want to find out whether it's a safer product. What if it turns out through their tests they find out it's an unsafe product?
I don't think that's been the result. So I don't think they have to face that question.
Okay,
that's a hypothetical question.
Well, it's a hypothetical question, and I want your answer to that hypothetical question. They're doing tests. When you do a test, trying to find out the information. They find out it's safer. They find out it's healthier. You've stated to us that they don't plan to disseminate that results of that information. But on the other hand, if they find out it's increasing the smoker's risk of heart disease or cancer, will they bring that product to the market?
Well, the full scientific results will be disseminated. The company is currently preparing for publication a approximately 700-page report on the tests that were done. Those test results will be available to everybody. Indeed, the company would be...
Well, they will make the results of their tests available to everyone?
Yes, indeed.
Okay, so then we'll be able to find that information
Absolutely.
out.
And
now, Mr. Hutt, when he met with Peter Hutt, when he met with people at the National Cancer Institute, acknowledged that this new RJR cigarette would be useful because it could reduce the risk of cancer. And your client maintains that there's a lower tar level in this new product than in conventional cigarettes. If those claims are being made, you've testified that the company will not make any claim or representation that the new cigarette is safe or safer than any other cigarette. Why are you so concerned that we know you are conducting and disseminating the results of your research, and is your research unrelated to health concerns?
First off, Mr. Chairman, Mr. Hutt has stated that he did not make the statement attributed to him by Mr. Davis. He denies that he made that statement. Second, Reynolds has done testing on the product. I assume no one would object to a company doing testing on its product. Having done the testing, Reynolds is making the test results available. I can't see any basis for criticizing the company for making the test results available. The company will not make any claims or representations for the product that it is safe or safer than any other cigarette. It is a cigarette. It will carry the Surgeon General's warnings, just like all other cigarettes, and will be marketed and labeled and advertised as a cigarette.
So this is just a product. This is just a new product. Some people have suggested it's a valuable new product because it's safer, but your client isn't making that representation. It's just another product to deliver, to market, to profit from, to deliver nicotine.
No, not to deliver nicotine, to provide smoking taste and enjoyment to adult smokers.
Do you deny there's nicotine in that product?
Oh, no. I deny that that's the intended use of the product, however.
Thank you very much. Mr. Whitaker?
Thank you, Mr. Chairman. The fantasy level is increasing. Dr. Cooper, do you take the position that cigarettes are not dangerous to the health of the smoker and a leading cause of death in this country? Yes.
I'm not a doctor.
I'm sorry.
I'm Mr. Cooper, sir.
Mr. Cooper.
Reynolds' position is that and it's well known, I'm sure you're familiar with it, Mr. Whitaker, that there's been no proof as to the causes of the diseases attributed to smoking, that it's an open question. Reynolds has presented that position in many forums for some time.
Dr. Blau? I'd like to ask how you can expect us as public officials to take the judgment of an industry that is literally making billions of dollars at the demise of our public's health, and in opposition to the opinions of our nation's health officials who have nothing to gain monetarily. How you can be so opposed in contradiction of the evidence?
Yes, sir. I'll be glad to respond to that specifically. I am here to talk about the quality of the scientific evidence and the clinical evidence presented in the Surgeon General's report. And the statements and conclusions of that report are simply unsupported by the data from even NIDA, which supposedly provides the data to support this. Regardless of the good intent of that report, bad science should not support a conclusion. The American people have the right to know that a conclusion is unsupported or partially supported, as opposed to the implications of full scientific support for the conclusions presented in that report.
And you expect the American public to believe the Tobacco Institute, who has everything to gain by continuing to market tobacco products, versus our public health officials who have absolutely nothing to gain monetarily?
I expect the American public, by and large, to intelligently assess such statements as cigarette smoking is an equivalent addiction to cocaine and to the opiates such as heroin. I don't know of anyone in my clinical practice that I've ever seen, no matter how emotionally disturbed they were, who would equate these two. Certainly in my work with normal people and in my work in police departments around the United States, I couldn't think of a single person who would not find that concept ridiculous. So I would count on the intelligence of the American people to see this as less than supported and not in keeping with common sense and their own observations of what really is in the drug culture of America, as opposed to the smoking of cigarettes as a personal choice of adults.
Well, Dr. Blue, you, on page 6 of your testimony, make a statement to the effect that there is, quote, no substantial scientific evidence that smoking creates a physical dependency to nicotine. And I'm here to tell you that as a former 3-pack cigarette smoker who quit, you're crazy.
With all due respect, sir, I smoked 3.5 packs a day for 25 years, and I quit, and I suffered no after effects. I'm sorry you did, but that's a personal experience and not based on scientific research.
Bruce.
Thank you, Mr. Chairman. I thank the panel, but I think I'm going to direct most of my questions to Mr. Cooper, since I've been asking questions on the legalities of what we're doing today. Has FDA ever asserted jurisdiction over cigarettes, and if not, why not?
FDA has asserted jurisdiction over cigarettes that made claims of positive therapeutic benefits, and there are two court decisions reflecting the agency's actions in that regard. In other instances, the agency has refused to accept jurisdiction or take jurisdiction over cigarettes. In 1977 and in 1980, it issued decisions denying petitions from Action on Smoking and Health, which put before the agency essentially the same kinds of allegations with regard to nicotine and its pharmacological effects, as have been discussed recently as a result of the Surgeon General's report. That petitions also asked the agency to ban filtered cigarettes and to ban cigarette filters that are detached from cigarettes. And the agency, relying on its interpretation of the law, not exercising discretion, declined jurisdiction, said it didn't have jurisdiction as a matter of law, and it was upheld in the federal courts. That's the record of FDA precedent.
Right. And those two court decisions, was it a question of whether or not it was an abuse of discretion, or was it on that the agency had operated correctly under the law?
No, sir. There was no discretion involved. I read the same cases that Mr. Schultz read, and I just read them differently. There wasn't any discretion. FDA interpreted the law. The court upheld FDA's interpretation, deferred to FDA's interpretation, said it was not contrary to the law.
And give me a layman's definition of FDA the Act's definition of a drug that would get this. What is a drug in layman's term?
Basically, a drug is a substance whose intended use is to deal with disease, to treat disease, to prevent a disease that is caused by something other than the substance itself. And it's a substance that's marketed with an expressed intent to affect the human body. The law distinguishes between a claim that a product will have no adverse effects or fewer adverse effects. That's not a drug claim. And a claim that a product will have positively beneficial therapeutic effects, that is a drug claim. And the FDA precedents and the judicial precedents are very clear on that distinction.
And does this new cigarette make any claims that would bring it under this definition of a
Reynolds
drug?
has announced that it will make no such claims.
How about health claims about the product? Will there be any health claims? And if they were to make a health claim, what kind of health claim would they have to make to bring it under FDA jurisdiction?
Bring it under FDA jurisdiction, they'd have to make a claim of positive therapeutic benefit. And the company has said it will make no such claim.
For example, give me an example. It'll make you feel better, look younger?
Well, look younger probably isn't a drug claim. That's probably a cosmetic claim.
Give me a therapeutic claim.
Therapeutic claim is that the product will help you lose weight, prevent obesity, that the product, if someone were to claim that a product would positively prevent heart disease from overeating or from some other cause, that would be a therapeutic or medical benefit. If I put out a cosmetic and I claim that it won't cause an allergic reaction, that it's a hypoallergenic cosmetic, that's not a drug claim. And FDA has been very clear about that.
All right. We've been talking about nicotine today. How does the question of nicotine fit into jurisdiction? What has the FDA said about nicotine? Does it exert jurisdiction over nicotine products? And if it does, how does that fit into the whole question of this new product?
Well, FDA in 1980 and in 1977 considered the question whether the presence of nicotine in cigarettes makes cigarettes a drug. And it said that even assuming that the nicotine is a very pharmacologically active substance, assuming that all of the allegations of adverse effects from nicotine are true, making that assumption, nevertheless, cigarettes containing nicotine naturally are not a drug.
All right. One last question. There's been discussion here about nicotine also and the derivation. People have said that the nicotine in this new cigarette is not derived from the tobacco leaf in the cigarette. It's my understanding that the exclusive source of nicotine will be a tobacco leaf. They've been talking about patents, international and national patents. Where does the nicotine come from?
The only nicotine in this product is naturally present in the tobacco. No nicotine is added. Patent matter is just a red herring. You don't patent a product or a cigarette, you patent an invention. And an invention can later be embodied in a variety of products. If I invent an internal combustion engine, that's the invention I patent. I can later use it in four-wheeled vehicles, three-wheeled vehicles, tractors, whatever. Four wheels are not essential to any particular embodiment of that invention. When I then design a Chevrolet, four wheels are essential. It won't go on three wheels. Similarly, tobacco is essential to the Reynolds product as it will be marketed.
Gentlemen, yield to me.
Happy to yield, Mr. Chairman.
So, is it your testimony, Mr. Cooper, that the only nicotine that will be in this product will be from the tobacco in the product itself and not from a capsule that will contain nicotine?
Well, let me explain, Mr. Chairman. The capsule will contain sprayed, dried extract of tobacco, which is tobacco that's been put through a water process, is used in many cigarettes. Like all tobacco, it has nicotine naturally present in it. So there is nicotine that comes from that tobacco, which is in the capsule. Nicotine comes from the cut tobacco leaf, which is in the tobacco roll in the product.
What percentage of the nicotine will be from the capsule as opposed to the tobacco that will be in the product?
I'm not certain of that. I believe it's approximately 70% is from the tobacco extract in the capsule. I will check on that, and if I'm incorrect, I'll submit a correction for the record. And the rest of the nicotine comes from the tobacco leaf, and it's not clear, it's possible that some comes from the tobacco paper filter, which is also made from tobacco. But there is no added pure nicotine or nicotine from any non-tobacco source in that product, as I understand it.
Thank you, Mr. Chairman.
Thank you, Mr. Bruce. Mr. Belaley?
Thank you, Mr. Chairman. Dr. Raffel, what do you do to help people deal with the urge to smoke when they're trying to quit?
The first thing I do is I explore with them the fact that it's not an addicting substance and that they're not going to go through a withdrawal the way that they would if they were using an addicting substance such as heroin or cocaine. I describe with them that they may or may not experience some tobacco abstinence discomfort, and that the amount of discomfort can be very variable and may not be present at all. I'm sorry that Mr. Whitaker isn't here. I would have added that the amount of discomfort that they can expect would in no way begin to approximate or even vaguely resemble the amount of discomfort and distress that a drug addict is experiencing during their withdrawal. So I try to reassure them.
Have you had extensive dealings with drug addicts, people trying to withdraw from hard drugs?
Yes.
I see. So you're speaking from personal experience?
Yes, this is my clinical experience both with drug addicts and with people who are stopping smoking.
Well, doctor, can people freely choose to go back to smoking after having quit for a certain period of time?
That's been my experience, and in fact the curve that was presented earlier up here regarding return of smoking paralleling heroin and cocaine is the same curve that my clinical experience and research indicates occurs with dieters. People who start out a diet will go through the diet for a while, and then their rate of, we can call it relapse or return to an old habit pattern, is essentially identical with this pattern.
Not, you've dealt with dieters too?
Yes, oh yes. Treated many. I have 6 in treatment now.
I see. Dr. Blau, do people smoke cigarettes for reasons other than to obtain the effects that may be associated with nicotine?
Yes, sir.
Would you describe them?
Sir?
Would you describe some?
Certainly. People smoke cigarettes for a variety of reasons. They smoke cigarettes for the taste, for the sensation, because other people are smoking and they socialize with them in that way. They smoke cigarettes to give themselves something to do with their hands. The main reason seems to be pleasure and taste.
Well, we've heard a lot of talk today about intoxication. Clinically, what are the distinctions between the intoxication associated with heroin and cocaine and those which are claimed to be associated with nicotine and smoking?
First of all, Mr. Blaley, I do not believe that people who smoke are intoxicated. Studies that characterize nicotine as an intoxicating drug are describing enormous dosages of the drug to the point where it's toxic. People, on the other hand, who take crack cocaine or morphine or heroin are unable to reason. Their view of the world is clouded. They cannot make reasonable decisions. With the new epidemic of crack cocaine, they become dangerous. People who are ordinarily mild-mannered and law-abiding will attack and even kill other people. We're talking about a very significant change in the personality of the individual, whereby they become a danger to themselves and a danger to others. When we look at a chart such as that on annual deaths, and one sees alcohol and drugs at a very low level, I wonder where the concern is for the 60% of highway deaths that are drug and alcohol related, the 60% of suicides that are drug and alcohol related, and the over 60% of homicides which occur by or to an individual who is under an intoxicating, addictive drug.
Dr. Blau, one last question. You mentioned in your statement that the Surgeon General's report may create false hopes that nicotine gum is an effective way to quit smoking. Would you elaborate on the false hope point?
Yes, sir. When I read the Surgeon General's report, I was very surprised to find that they had omitted reference to a large number of studies which clearly indicate that the use of nicotine gum as a therapeutic agent has a very low rate of success and is exceeded by such simple things as advice from a physician.
Thank you, Dr. Blau.
Yes, sir.
Thank you, Mr. Chairman.
Thank you, Mr. Bliley. Gentlemen, we appreciate your testimony. We may have additional questions from members of the panel, and we'd like to ask you to respond in writing to those questions for the record. Thank you for being with us. Our last witness on this hearing this morning is a colleague of ours, a very distinguished gentleman from the state of North Carolina, Congressman Steve Neal. I'd like to ask him to come forward. Yes, Mr. Bruce.
While Mr. Neal and all the witnesses are trading places, let me just take the honor of introducing my father to the members of the panel here and to the committee. He's come out from Illinois today, and I'm happy to have him with me today. My father, Lloyd Bruce.
We do want to welcome him. We're pleased to have you with us, Mr. Bruce. Mr. Neal, we're pleased to have you with us. Your written statement will be in the record in full. What we've done for every witness this morning is to limit them to a 5-minute oral presentation, and we'd like to ask you to keep to the 5 minutes as well. We're pleased that you're with us, and we want to recognize you now for your presentation to us.
Thank you, Mr. Chairman. I'm just...
there's a mic. There's a button on the mic that will...
There's a little light on.
Pull it close.
Mr. Chairman, my written statement is very brief. If you would indulge me, it might run a minute or so over, but I'll try to keep it very brief, and I thank you. And Mr. Chairman, I appreciate the opportunity to comment on Surgeon General Coop's report, which claims that tobacco is as addicting as heroin and cocaine. Mr. Chairman, I want to point out here at the outset that the congressional district which I represent is the home of R.J. Reynolds Tobacco Company, has a big American tobacco company plant, and in addition, I have thousands of constituents who grow leaf tobacco. Tobacco is a very important agricultural product to my district and, in fact, to the whole economy of our state. So I think you recognize that I'm have an interest in this, clearly an interest in the subject. I must point out also, though, that I've been highly impressed that a number of our colleagues here and a number of editorial writers from areas of the country which have no such interest have been highly critical of the Surgeon General's approach. Our colleague Larry Smith of Florida, for example, has authorized me to submit for the record a statement he made on the House floor on May 17th. I'm told that he would be in person here to deliver it, but that he had a previous commitment in his district. Let me quote from that briefly. The problem, Mr. Smith says, the problem is that this statement compared nicotine to heroin. While I commend the gentleman for decrying the effects of nicotine, I also would suggest to the Surgeon General that lumping nicotine and heroin is a terrible injustice to both, to the American people. Heroin is a far more dangerous drug from the standpoint of a single-dose usage. Heroin is a killer, and it kills now. It kills the first time you use it. It has the capability of killing you immediately. Nicotine does not. He goes on to point out that comparing nicotine and heroin trivializes the problem with hard drugs and trivializes the terrible effects of heroin. And he urges the Surgeon General to make a clarifying statement to that effect to the American people. Mr. Chairman, as you know, Mr. Smith is a member of the Select Committee on Narcotics Abuse and Control also. Our colleague Tom DeLay of Texas, again representing a district which produces no tobacco and manufactures no cigarettes, in a floor statement on May 18th, said this: lumping cigarettes in the same category as illegal, mind-altering drugs such as heroin, cocaine, PCP, and crack is wrong and frankly dangerous. He says, I'm not here to argue over the relative physical health effects of any of these substances, but I'll say this: nicotine is not tearing at the very fabric of our society, as are these drugs. Nicotine is not consigning millions of our children to a mindless, hopeless existence, as are these illegal drugs. Nicotine is not behind the crime wave that has made a normal existence in every inner city in our country impossible. Try walking a mere 10 blocks from the very chamber we're standing in right now. It's not the cigarette smokers who will hold you up. I know of no law enforcement personnel killed in pitched gun battles fought by gangs of rival cigarette dealers. We are spending billions of dollars to stop the drug trade with only marginal success. To put cigarettes in the same level as this scourge is ridiculous, he goes on to say. The Boston Globe, a major newspaper in a state which has no economic ties to tobacco, on May 19th said in an editorial, smoking bears no resemblance to drug abuse or alcohol abuse. Smoking does not affect mental acuity, nor temporarily derange a person, nor produce so much as a lull in anyone's contact with reality. Smoking does not cause people to rob their neighbors to support the habit. Nobody beat their spouses or children in a mood-altered frenzy, nor drive crazily, nor aid international drug cartels. Smoking does not endanger neighborhoods or contribute to street crime, clog courts, or fill prisons. For the right reasons, smokers should stop, the editorial says, but that goal is not advanced by equating smoking with drug abuse or alcohol abuse, nor should it divert attention from those ruinous addictions. In the same vein, the Indianapolis Star said, classifying the dangers of nicotine with the horrors of heroin and cocaine is misguided zealotry. It downgrades, even discredits, the nation's campaign against hard drugs. Indeed, the Surgeon General's latest attack on smoking is itself generally irresponsible. His enthusiasm has turned to zealotry and is on its way to fanaticism. His concern for the people's health is no longer mixed with a healthy respect for individual rights and individual responsibility. The Kansas City Star added, if you have any doubts as to the ridiculousness of Coop's contention, ask yourself a question. How many people have turned to crime to support a tobacco habit? Mr. Chairman, Mr. Leonard Larson, writing in the Washington Times, put it this way: meaning no offense to Dr. Coop and intending no support for the tobacco industry, it's still appropriate to suggest that Dr. Coop has actually diminished the attack against a serious national health problem by hyping a dangerous habit into an addiction. His commentary on tobacco smoking as addiction may prove to be good for the business of the nicotine cure peddlers and the tobacco-chasing lawyers, but for cigarette smokers, he has just handed them better excuse not to quit. I can't, I'm hooked, I'm an addict, the Surgeon General said so. When cigarette smokers say they want to quit smoking but they can't, then they haven't yet really decided they ought to quit smoking and that they're going to quit smoking. By telling them they're addicted, Dr. Coop encourages them to push the decision farther away. Mr. Chairman, I'm no scientist, nor am I an expert on the exact definition of the words and phrases used in the report, but for the Surgeon General to suggest that cigarette smoking is any way comparable to the abuse of hard drugs is not only an insult to the intelligence and common sense of the American people, it's the wrong signal. I do not know a parent in America who would not prefer to have his son or daughter take up smoking than to take up heroin, cocaine, or other hard drugs, and to suggest to young people that one is no more dangerous or habit-forming than the other is certainly counterproductive. Mr. Chairman, Surgeon General Coop's claim that tobacco is comparable to heroin and cocaine addiction is intemperate, inaccurate, and very counterproductive in our nation's effort to successfully deal with our nation's serious hard drug problem. And I thank you for the opportunity to address the committee.
Thank you very much, Mr. Neal. Mr. Blindley, do you have any questions?
No, I just want to thank your colleagues for taking time out of the busy schedule to be with us this morning. And
Thank you.
Mr. Chairman, before you adjourn this hearing, I would like to commend you on the fair and even-handed way that you have conducted this hearing. Thank you.
Thank you very much. Mr. Bruce, any questions?
Just to thank Mr. Neal for coming and to the other witnesses who took their time to appear before us today and for your conduct of the hearing.
Thank you.
Thank you. Well, Mr. Neal, I do thank you also, and I appreciate the views you've expressed to us.
Thank you for holding this hearing.
Thank you. That concludes the business of this hearing. We stand adjourned.
If you'd like more information about this hearing, you may write to the House Health Subcommittee at 2415 Rayburn Office Building, Washington, D.C., 20515.
The C-SPAN Update, the weekly newspaper of America's network, helps viewers track special events that our cameras record. Whether it's a speech by the president, a former president, a presidential candidate,